Welcome back, everybody. It is time for July's Ask Me Anything. Welcome, everybody. If you are new here, I'm Dr. Lily Johnston. I'm a board-certified vascular surgeon, but I specialize in cardiometabolic prevention, so hopefully you will never need me as a surgeon. All right, I'm excited. We already have questions in the chat. We have some anonymous questions. We're going to dive right in. Salzburg's. How credible is the ADMA test as a measure of vascular health? What steps can be taken to lower elevated ADMA into the reference range? ADMA is a surrogate marker of nitric oxide. So nitric oxide is the molecule, it's actually gas that helps the blood vessels relax. And it's very important. It's also super short-lived in the circulation, so we cannot measure it directly very well. ADMA is the best proxy that I know of, at least chemically, for us to understand something about the nitric oxide pathway in the body. I don't know how terribly well validated it is. I do check it from time to time in some patients. I have gone away from it more and more because I have found it very difficult to move the needle, and I don't understand as much as I think I need to about that test to make it a super high priority for many of my patients. That being said, if we have everything else all dialed in, people are still not feeling their best, or they're concerned that there are, the last 2 to 3% of optimization that they want to know about and try to target, I think that is a great place to, be for that particular test. Because it's focused on nitric oxide, we are then going to pursue those things that nitric oxide or that drive improved nitric oxide. So that would be first and foremost exercise, right? This is where exercise is a drug. We use it like this, we prescribe it. And I think probably cardiorespiratory fitness is important for this. I do also believe strongly in resistance training. How much that drives nitric oxide one versus the other is not as familiar to me, so I'm not going to put a huge stake on that per se in terms of the resistance training piece, but I think both of them will drive nitric oxide to some extent, and both are critically important for that. We can also think about, supplementation to help with nitric oxide synthesis. We could also think about potentially some of the molecules that prevent the breakdown of nitric oxide. Those would be the phosphodiesterase 5 inhibitors, PDE5 inhibitors. Those are the erectile dysfunction drugs, right? Cialis, Viagra, and those will prevent the breakdown of nitric oxide in the blood. Have I seen those directly impact ADMA? I haven't had enough patients on them and done serial testing to know for sure. But again, the purpose of all of this is to improve nitric oxide, improve vascular relaxation. That is the strategy I would take when we're ready to target that last 2 to 3% when everything else is dialed in. Donut time. Dr. Lily, can I find reliable studies with donuts specifically proving causation of heart disease? Not yet. We're still waiting for that trial donut. Salzburg's again, how do I compare EndoPAT and Vendis test for assessing vascular health? EndoPAT is a vascular relaxation one that I've heard of. I have never used it, and I have never even heard of Vendis. We can look it up maybe for another time. Flow-mediated dilation is a functional measure where they are looking at how much the brachial artery in the arm will expand after challenge with a blood pressure cuff and a bit of ischemic time. These are not particularly well used in the United States. There's a bit more of an emphasis on this in Europe, for example. I'm not commonly using them. Let me put it that way. That's, I haven't found them to be super compelling in terms of the data, and I've not found them to really help me move the needle with my patients. So maybe they're getting better over time. I am not using them actively in my practice at this point. William Henry, welcome. LPA is 8.4. Will that help my vascular health? Your ApoE2 fan from Julian. Hope it is a beautiful day out there in Julian for you, William. It's neutral, right? So LPA is a problem when it's too high. When it's low or low normal, we would call that, you would just have baseline risk. So it's not a help, but it's not a hindrance. So you have that going for you. It's a good thing. Your ApoE2 allele will also probably be more helpful from that perspective in terms of your lipid trafficking system and ApoE things going on. But it's always a good thing to have a good hand from mom and dad in your pocket. All right. Father Charm, what are my thoughts about arterosil regarding plaque regression? Please consider doing a full nerd video. Father Charm, how did you know we were in the nerd club here? Yes, I think actually, so arterosil is a proprietary supplement from Bicuspid, and it is a version of ramdan sulfate. Ramdan sulfate is derived, I think, from a marine source seaweed, I believe. It has a bunch of papers to its credit. They're all small, like a lot of the supplement trials. Do I think it's harmful? Not to the best of my knowledge. Do I think it's helpful? Again, I think it belongs probably in that last 2 to 3%. And I am not prepared to say more about it at this time. We will add it to the list of things that we need to talk about in terms of deep dive nerd videos in supplements in particular. So we're also on that list that I have not forgotten about. You know, you think that I have because we haven't done them yet, but I have not, would be berberine and dihydroberberine in particular. Aged garlic extract was also something that was promised a while ago. We have not done yet, and we will put ramdan sulfate on that list as well. All right, Lisa, you are so welcome. Thank you for being here. I'm having a great weekend. I hope you are too. All right. Wayne Oakley, for a person with a CAC score of 0, but CT angiogram shows 25% soft plaque in a couple of places, is secondary prevention such as Repatha warranted? You have plaque and you have soft plaque, which is an excellent opportunity to try to nip this in the bud before it ever becomes a problem. What I tell patients when we find small to moderate amounts of mixed or soft plaque on a CIMT is, if this never got worse, you would be in great shape for the rest of your life. Our job is to understand what is driving the formation and progression of plaque and to stop that now so that this plaque can either regress or stabilize and stay put and never become an active erupting volcano to cause a heart attack or a stroke, right? A small amount of plaque is really not ultimately the enemy. The enemy are the events related to plaque rupture, like heart attack and stroke. Obviously, the more plaque you have, the more likely those are to happen. And also, the more likely you are to have other issues related to impaired blood flow. So even though it is not the case, generally speaking, that slow progressive blockage of the artery is what causes these problems, it causes other issues. It causes chest pain with walking or leg pain with walking. It can cause reduced cerebral oxygenation and perfusion, which nobody's quite clear yet on whether that's related to cognitive function, but how could it be a good thing to have less blood flow getting up to your brain? So all that to say, if you understand what's driving your plaque, then I think this is the opportunity of a lifetime, really, to stop it. But whether that is lipid lowering, whether that is attacking your insulin resistance, whether that is figuring out what genetic predisposition you have, what metabolic issue is going on, whether it's your periodontal disease, your visceral adiposity, your inflammation, I don't know for you what is driving that plaque progression. If your lipids are out of whack, I do think that's a reasonable thing to consider, but especially because you have the luxury of some time, right? You do have plaque, but it's, 25%, it's a mild stenosis is how that would be characterized. Then I think it's important to do everything in our power to optimize the lifestyle first as our foundation. And then absolutely, we can progress into the other tools that are available to us, be that Repatha or enlicitide, which is the new one that's coming out. By the way, I have not been able to prescribe this, or I have not seen it in pharmacies yet or on GoodRx. So maybe wait a few more weeks before you're starting to ask your physicians for Lipfendra, if that is something that you're considering or you're interested in, because I have not been able to get it yet for my patients. That was an aside. GLP-1 receptor agonists, whatever the tools are that are at your disposal to help with your particular flavor of plaque progression, by all means, add those in, but don't use it as a reason not to optimize that foundational piece first. Okay. Amelia, hi, welcome. My PCP recommended that I take MCT supplements or add C7 MCT oil to my coffee, but my triglycerides are already high, as are my other cholesterol numbers. I'm confused. Thanks. Okay, medium chain triglycerides, MCT, and it's probably C8 or C10 are the couple that are typically commercially available to add. Medium chain triglycerides feed the ketone synthesis pathway in the liver, and they bypass some of the regular digestive pathway for fats, and they get shuttled directly into the liver, and so they're attractive that way. They can also cause some GI distress for this, for related reasons, so be cautious if you're adding them. And if I had to guess why your doctor was encouraging that, I would say they're trying to get you ketone synthesis, if maybe, I don't know exactly what they're thinking. In certainly the space that I operate in most of the time, if people are recommending MCT, it is for that reason. And you can do that with MCTs. You can do it with exogenous ketones. You can also do it with a nutritional ketosis approach, which would be reducing energy and carbohydrates in particular, for most people, to achieve therapeutic ketosis. And it's possible that the reason for this is to help drive hunger down and drive overall energy intake down so that your metabolic syndrome, if that's the reason for your high triglycerides, could resolve. But you may have genetically elevated triglycerides. I don't know for sure. MCT by itself is not a treatment to lower triglycerides, like just like as an independent mechanism. That's not really how that works. In contradistinction, for example, to DHA, the omega-3 fatty acid, which is icosapent ethyl Vasipa, that will directly lower triglycerides. MCT does not, to my knowledge, do that. I could be wrong about that, but as far as I know, it does not do that independently. So I have to imagine it's to drive ketones, but I'm not sure. Would need some more information before we can really kind of suss that all out. Mark Suave, okay. What can most people do to not have an early heart attack prior to age 60? Because we will all die of something. What can we do to push it off as long as possible? Great. This is what we do here. And the best thing you can do is figure out how much risk are you at? Because again, for all the world, these risk calculator equations, the PREVENT equation, pooled cohort equation, MESA, like they're all okay at a population level, but at an individual level, they kind of stink. Imaging is the thing that I think most people need to be doing in their 30s, 40s, and 50s to figure out how aggressive they have to be for these areas in their health. And I do honestly believe that much of this is a genetic component that is not directly related to your everyday. Also, that's not to ignore the everyday. Also, I find that documenting the presence of plaque on imaging is very motivating for people who have thus far been kind of ignoring the fact that they don't eat great and they don't exercise as much as they should, and they're not really paying attention to their sleep or their stress, and they think that they'll deal with that someday when they retire, when the kids are out of school, when this, when that. Having a concrete visual of the presence of plaque that may someday be the thing that causes your heart attack or your stroke is sometimes life-changing, right? And I don't like to scare people. I never want this to be a fear-based plan or process, which is interesting, is that's sort of what I'm saying, but it's not real, right? Because this is a silent disease, just like high blood pressure is a silent disease, and inflammation for many people is actually silent. They don't feel it, or at least they don't recognize that they feel it. Having this proof, this evidence that we have the plaque is really focusing, right? It allows us to have a target, a goal, a thing we can follow, something to measure. and it is evidence that our choices have real consequences. So you have heard me preach this till the cows come home. Everybody should have some kind of imaging. The younger you are, the more important that imaging should look for soft plaque. The older you are, the more acceptable things like a calcium score, which are only going to image hard plaque, or the assessment of calcium on a mammogram or other imaging tests can be. But the younger you are, the more important it is to have that assessment of soft plaque. All right. Tom Smith, 61 years old, bicuspid aortic valve. So let me finish the question, then we'll get to that. Echo shows mildly dilated ascending aorta, mild aortic stenosis. Other than biannual echo, I don't intend to get imaging in the future. Am I crazy? Okay. So the aortic valve is the valve which keeps blood flow moving out of the heart to the rest of the body and prevents it from coming back into the heart as everything squeezes, right? So the heart squeezes blood and it's supposed to go up the aorta through the aortic valve. And then as everything relaxes, including the aorta and the heart, there's potentially a temptation for blood to sort of suck back into the heart, which is not useful, right? We want it all out. So the aortic valve is a valve that shuts as blood begins the potential process of coming back into the heart and stops it, right? And prevents it. It also allows the coronary arteries to fill and have good flow that way. The aortic valve usually has 3 leaflets, and you can think of it, if you were going to look at it like down the barrel, it looks like a Mercedes sign. And so those 3 leaflets open and then they close. People who have a bicuspid aortic valve only have 2 cusps instead of 3. And for, I guess, mechanical reasons, those bicuspid valves tend to wear out much earlier in life, and people with bicuspid aortic valves tend to need those replaced much sooner than the average person might otherwise have an issue with their valve. And it is also sometimes associated with some connective tissue disorders or things like Ehlers-Danlos that can cause the aorta to be a little weaker and to be bigger than it would otherwise be. I would say the idea that, obviously, Tom, you're aware of this diagnosis, you're getting followed, it's being monitored. Do you need any other imaging? Probably. I mean, you're not getting any imaging of your coronaries yet. I am certain that they would image your coronaries before you ever got your valve replaced, but they probably won't image them before that. It's a very separate disease process. So it's not really speaking to the presence or absence of plaque. And so I still would say at this point, a CIMT, CCTA would be useful. CAC at 61 would also be reasonable. Certainly, if you get to a point of needing your valve fixed, they will check your coronaries before they do it to see if at the same time they needed to do anything to your coronary circulation, but they're not necessarily going to do it now early to let you know, hey, we should optimize your atherosclerotic risk burden. But you're here frequently. I'm going to assume that those things are largely in good working order for you. But just to be clear, your echo is not, an echo is an ultrasound-based test. It's not going to be able to see the coronaries or the presence of any plaque. Separate things. Navy retired. A new year-long study showed that in lean, metabolically healthy people, high ApoB levels and high LDL-C levels did not matter at all with regards to plaque in their heart arteries. That is a little bit of a generous interpretation of the KETO-CTA trial, which has subsequently been retracted. And the data that are probably more reliable from the other imaging companies are not yet published. And that said, the data are interesting. The baseline plaque burden is overall pretty low in people who are walking around with LDL cholesterols in the 200 to 500 range. And the progression based on my awareness of the non-clearly data is also low. And there are some regressors in the data set. That said, this is not yet peer reviewed. It's not published. It's not out yet. Do I think that there is a subset of people in whom LDL cholesterol or ApoB behaves a little differently? That's possible. Does it invalidate the lipid hypothesis? Not necessarily. Is it possible that LDL is necessary but not sufficient? What does that mean? It doesn't mean that just because you have elevated LDL-C or ApoB that you will, of course, 100% of the time get plaque as the result of those levels. No. Does it mean that if you have those elevated levels and a second hit, like inflammation, like high blood pressure, like hyperinsulinemia, that then those levels might become a problem? I think that's probably the most generous and likely explanation of where we are with LDL-C. Now, why does mainstream cardiology continue to have a laser light focus on ApoB and LDL-C? It is the one in their gestalt, right, in their worldview, that is the easiest to manage. And again, in their perspective, is the least consequential to manage. I've talked to enough patients to have a slightly more nuanced perspective on that. And my impression is that once you have plaque, there is an important concept about what you're going to do about how you manage it. So does somebody with no evidence of soft plaque on a CCTA need to manage an elevated ApoB? Nobody knows for sure, right? Does it mean that in 10 years there won't be consequences? No. Does it mean that they are at low risk in the very near future? Absolutely, they're at low risk. They have no plaque. Could they lower it and even hedge their bets further? Potentially, yes. Do people want to be on a medication that may save them a 0.2% chance of having an event sometime later in life? Probably not. Do they want to adjust their way of eating to do that? Probably not, because they may be doing this for very specific reasons. So the jury is still out, in my opinion, on what the role is of elevated ApoB in otherwise metabolically healthy people with zero plaque. In people with some plaque, I do think that there is a threshold effect of ApoB, meaning it may not make that much difference whether it's 100 or 200 or 300, but if you can get it under 55, you may be able to halt the ongoing inflammation and progression of plaque in that particular individual. Is that the only way? Nobody knows. It is the most studied way that we have to address plaque regression or stability. And again, lots of conversations about why that's the target. That's for another day. All this to say, yes, I think that there are people in whom elevated ApoB is less problematic than others. Am I prepared to say it's completely benign? No, not yet. We have 1 year of data, right? That is not a super longitudinal evaluation. And I am trying to be as faithful to what we actually know as I can, and be willing to acknowledge that we know less than we think we do. All right. Any word on the oral PCSK9 inhibitors? Yes, I mentioned this. So Lipfendra, enlicitide, has been FDA approved. I have had at least 3 patients reach out to me in the last week asking to have it prescribed. It is not yet available in my medical record to prescribe. And then I was just going to check on GoodRx to see what the cost was going to be. And I can't find it on GoodRx yet either. So that tells me that though it's been approved, pharmacies don't yet have it in stock and final pricing details have not been arranged. My guess is that insurance carriers are also not quite ready to begin prior auths or prior authorization steps and processes, and haven't decided if they're going to prefer oral versus injectable. So how we're going to get access to this, what it's really going to cost, I'm not sure yet, but stay tuned. I think we'll know that pretty soon. Abdul, doc, my LDL below 15, ApoB 44, with rosuvastatin 20, ezetimibe 10. With 10 and 10, LDL is 30, ApoB 48. I wanted ApoB 20 to 30. Okay, I don't actually hear a question in there. Nobody knows how low is low enough. Certainly there does seem to be some linear impact on events at a population level. What is the absolute risk reduction for you from an ApoB of 60 down to 30 down to 20? Not clear. Depends on what your baseline risk is, what else is going on. And, for oral agents only, that's not a bad drop. But if you're having any issues with glycemic control or myalgia or other things, then certainly you could revisit those dosings. All right. 345 DF, what is the accuracy repeatability of a CIMT test? Great question. Depends entirely on how it is done. So CIMT, carotid intimal medial thickness. This is the measurement of the two innermost layers of the artery wall, the intima and the media. The adventitia is the third layer. That's not part of it. Why do we measure this? We measure it because the intima and the media are where plaque forms. And we get thickening of that layer before we actually turn it into a plaque. And it allows us to have both an assessment of plaque if it's there, but also the overall health of the artery wall and how much activity there is going on in that subendothelial space. So you can take a single picture on any ultrasound, some handheld thing, and have a button that says CIMT. It'll draw lines where it thinks the walls are, and it'll spit out a number. If that's how you measure CIMT, it is not very reliable. Why is that? The artery is a three-dimensional structure. So if you imagine, right, it's this whole long tube, it's got a whole back wall to it, and an ultrasound is a two-dimensional picture, and the resolution of ultrasound is actually quite high. So it's a very thin piece of this whole big structure, and you're getting one snapshot. Most of the CIMT buttons on an ultrasound will measure like this much of an artery that's, this long in the picture frame. So did you pick the right place to measure? Which part of the wall is it? This is why CIMT has been sort of demonized as a bad test, because in the early studies, when people were taking a couple of little independent measurements like that, they weren't very reliable or repeatable. How do you fix that problem? You get as much data as you can and as granular as you can. So you get a high quality ultrasound machine, you make the settings on the ultrasound itself so that you're getting as much raw data as possible, and the ultrasound isn't smoothing it out and averaging things and making it more visually appealing. And then you have a group of people, a lab, who will take hundreds of measurements along as much of the wall as you can give them in a picture and average that out. When you do that, you make CIMT a very reliable, repeatable test to hundredths of a millimeter. That is why I harp again and again and again about a high quality CIMT. CardioRisk is the company that I use. I pay them for their services, right? I don't get anything from them to say this. I just believe in the technology. It is the only thing where I have had to go be tested to make sure that I am capable of providing them the quality of the images that they need, and that I have the technical capacity to scan the patients. So all that to say, when done in the right hands, it can be very reliable, very repeatable, and sensitive to a very small amount of change, which I love because it allows me to make changes in patient care year to year. And even if we don't see a huge amount of plaque regression, if the IMT starts to drop, or the IMT even just stays the same, but the patient continues to age. Arteries are supposed to age with us and thicken naturally over time. But if you are aging and your arteries are not, actually that's a great thing. That tells me we're doing a pretty bang up job of controlling the risk factors that would lead to plaque formation or progression. If, however, the IMT is increasing, and perhaps disproportionately to your age, right, faster than you are, that's a sign that we have missed something. There is some ongoing process in your body, in your artery walls, that we have not managed adequately. So for all those reasons, I like CIMT. In my hands, it's very reliable, at least according to the best data from Todd Eldridge at CardioRisk. So I think that's great. I think the resolution is actually higher than that of CT right now. And, the downside is it's the carotid arteries in the neck. It's not the coronaries. It's never going to be the coronaries. Overall, the concordance is about 90%. So I think that's great. But for all those things, it's not available to absolutely everybody. And so other imaging is always a reasonable idea if that's what you have access to. All right, let's pop over to one of our anonymous questions. What causes a person to have an enlarged heart and reduced ejection fraction? I was obese with high blood pressure, high pulse rate, and a CAC of 500. So the heart is a muscle and it has to work very hard to pump the blood. If your blood pressure is high, then it has to work even harder. And if you are not giving the heart enough oxygen, because there are areas of narrowing in the blood vessels that supply the heart, which is what CAC will measure, then your heart may get tired. And if it gets tired, then it may not pump as strongly. And that's what you get when you have a reduced ejection fraction. The heart is basically wearing out. It is not able to supply as much blood as your body needs. And eventually, over time, the high blood pressure will cause the heart to enlarge and stretch out as a result of that pressure, because again, the heart is fatigued, the muscle is weak, and it's not able to supply itself with the amount of oxygen and nutrition that it needs to function optimally. Reduced ejection fraction is not always permanent. It can recover with appropriate medical therapy, so that's a very positive thing. All right. After 2 years of medication, the EF and enlarged heart reversed itself, technically no longer heart failure with very minimal weight loss at that time. So again, the body's ability to compensate for this is good. You know, would it be even better with weight loss? Yes. Typically, obesity will cause heart failure with preserved ejection fraction, which means largely that the heart doesn't fill very well. It's called diastolic dysfunction. So heart failure with preserved ejection fraction is typically what is associated with the diagnosis of obesity. That's a little bit of a different beast. It's a bit harder to diagnose. And that is typically what we see resolve much with fat loss. But certainly the reduced ejection fraction versions of heart failure are, they can be related to ischemia, so ischemic cardiomyopathy, meaning the heart's not getting enough blood flow and that's why it is weak. There are also causes of non-ischemic cardiomyopathy, meaning the heart is weak and failing for other reasons, not having to do with poor circulation. All right, let's see. Can you exercise your way back to great cardiovascular health? You betcha, Mike. You betcha. So if you are starting from a very weak place, you've had a heart attack, you've had a stroke, you have bad peripheral arterial disease, cardiac rehab is perhaps the best option for somebody in that particular circumstance. It is a supervised program where they will kind of gradually escalate you through harder and harder tasks, but it allows you to be monitored and you have a lot of resources available to you. It is also sometimes done in a group setting, so you get a little bit of support, peer support, and connection and companionship, which is great, and an accountability buddy. So I would say if you are in poor cardiovascular health, exercise is great. If you need help getting there, please find a walking group. My friend Kim McNicholas has a great walking group for PAD warriors. If that is your jam, let me know. We can hook you up with that. Otherwise, cardiac rehab is a great way to go. You'll need a referral from your doctor, but you should be able to get one if you have cardiac disease or peripheral arterial disease. And otherwise, get a trainer, get a buddy. But I think exercise is one of the best drugs we have in the world. And I actually think both cardiorespiratory, like cardio, walking, running, jogging, rowing, swimming is great. But I also think resistance training is super important and may also support heart health or at least metabolic health to some degree. Do animals get cardiovascular disease or is it just a human thing? You can make animals get cardiovascular disease, but you have to work at it a little bit. And some of the original experiments relating to the cholesterol heart disease pathway were done in rabbits who do not naturally get atherosclerosis. You can force them to do it, but you have to change what they eat and provide a pretty unnatural set of circumstances. I think other primates get some atheroma, but again, typically not free living in the wild. I think it is a much more of an issue in captivity. That said, I am not deeply familiar with the data on this, and we'll have to kind of circle back and follow up with you on that one. Lisa, I am wondering, when a patient needs an emergency quadruple bypass, 4 surgeons, including a cardiologist, would a vascular surgeon be present as well? No. So coronary artery bypass is really isolated only to the heart. They will harvest typically vein from the leg, sometimes an artery from the wrist to use as the new blood vessel to go around the ones that are blocked in the heart. Oftentimes these are done with 2 surgeons, sometimes 3, 4 is a lot, but it's possible. There's not room for 4 people to typically be working together at the same time, but my guess is they were in and out and helping each other that way. Vascular surgeons are sometimes involved in cardiac surgery specific to the aorta, which is the big blood vessel that leaves the heart and brings blood to the rest of the body. There are places in the aorta, especially up in the arch area in the chest, where the blood vessels go to the head and to the arms. Those reconstructions can be pretty technical, and if they involve the heart, then you'll have a cardiac surgeon involved in that part and a vascular surgeon involved in reconstructing sometimes the arch vessels or even further out. Sometimes issues go all the way down into the chest, into the abdomen and the pelvis. Those are some of the biggest, longest cases in cardiac and vascular surgery. Those are often done as tandem combined operations with cardiac and vascular surgery together. All right. Tommy, can I go over the labs I care about? Yes, I will also direct you to the last video I did where I looked at my own labs, but I think everybody should have a blood count, a comprehensive metabolic panel, a fasting insulin. Between that and your metabolic panel, you'll get a fasting glucose. You can do a HOMA IR, and you should have uric acid, homocysteine. You should have a lipid panel fasting, ideally. And what else do I put in there? Somebody asked me about hormones. Sometimes I will test hormone levels. Which ones depend on patient's sex and stage of life. It is not something I do routinely. Hormones fluctuate a lot, and the levels are not necessarily representative of patients' symptoms. An iron panel with ferritin is a good idea for most people, at least once in a while, like once a year or at least every couple of years. Thyroid panel, TSH, free T3, free T4. Somebody also brought up reverse T3. I used to do that more than I do now. I had very few people for whom it was positive, but you could add that in there as well if you felt strongly about it. And ApoB, lipoprotein little a, at least once in a lifetime. What else? The NMR, the advanced lipid testing, that's sort of falling out of favor in the lipidology community. I still find it interesting if patients want to know, and it can sometimes guide therapy for sure. We talked about imaging. I won't beat that horse again. What else have I missed? Vitamin D. Everybody should get that checked. And I'm sure I'm missing something. I'll think of it. I'll come back to it if I remember it. All right. Another anonymous question. Pushing for a referral to cardiologist even without symptoms other than high blood pressure and heart rate improved the quality of my life and extended my life thanks to choosing an excellent doctor. Yeah, I think whether they're a cardiologist, whether they're a very in-tune primary care doctor, having a good clinician on your side to work through some of these issues with and be a little bit forward thinking is a great asset, right? And this is what I love to do for my patients. I wish everybody could have access to somebody like that in their corner. And if it comes up later, we'll talk about it, but it's not available to everybody, and it makes me sad. And it makes me sad too, because it's not that these doctors are bad people. The doctors that you have that are not helping, they started out wanting to help. They have largely, in my opinion, been beaten down by a system that is very broken, and they are doing their best to stay alive and function within it. But it is solely crushing the souls of many of us, and it's really, really difficult. So I would love to extend a little bit of grace to everybody who's still trying to make it work in the regular fee-for-service, hospital-based care systems. And I apologize on behalf of my profession if you are not getting the care and support that you deserve. I am really glad that a lot of you have told me that you are getting great support from clinicians in your own space. That's amazing, and I'm really happy to hear it. I know those clinicians get a lot of joy and meaning from helping patients like you. All right. Can HIIT training help with plaque buildup? Since HIIT is a specific training pattern, are there other training patterns which raise, drop heart rate? My question is because I like to be outside doing bike riding up mountains, so timing. Yeah, this is all, what do we have data for, right? You can't study the average mountain biker who's like up and down and up and down. Like they're busy riding up and down a mountain. They're not really here to participate in your clinical trial. The Norwegian 4x4 protocol is what was studied. So that's 4 minutes of high intensity with a 3-minute break done 4 times. And there's a little more to it than that. It's heart rate dependent, yada, yada. All that to say, there's another video on the channel about that. Is it possible that biking is pretty close or close enough? Sure it is, right? Is VO2 max the best proxy we have? Who knows? Maybe, right? Certainly that was, that had its moment in the last couple of years as like the target. I think if you are doing what you love and you're getting your heart rate up and you're sweating, you're in pretty good shape. I don't know how to tell you how to do that differently so that I can be sure, right? Nobody can be sure, even if you're following this Norwegian 4x4 protocol to the letter, that you specifically will have plaque regression. I have no way of knowing that. But do I think it's a great idea? Yes. Do I think it contributes to your overall health, longevity, and wellness to include some interval training or interval type training in your armamentarium of things that you do? Absolutely. Can I tell you exactly what the protocol has to be or how long or this or that? I can't for sure. But if you're outside doing what you love, I have it on good authority that will help you in the long run. I think that's going to be really great for you in the long run. Okay, where are we going next? Lisa, yes, you should get a CIMT someday. Mark, I've always wondered when it comes to cutting into the chest of a person, how do you keep them from bleeding out? Well, you go carefully. So if you are doing what I do and you're stopping or you're working on blood vessels, then you have clamps. You clamp the blood vessel above and below the area that you're working on, and you stop the flow of blood, just like you're working on a water pipe, right? You would shut off the water to that particular pipe before you would open it up and start working on it. Same thing with the heart. You can stop the heart or you can bypass the heart. Cardiopulmonary bypass was the technology that really opened the field of cardiac surgery up to where it is today, right? Because we can stop the heart. It's not so much the bleeding as the fact that the heart is like moving all of the time that makes it hard. You can actually do bypass surgery while the heart is still beating. That's its own special thing. But largely, the ability to put the heart to sleep safely, wake it back up, and stop it for a period of time without damaging it was one of the key things that made cardiac surgery into the field that it is today. And they got it wrong a lot before they got it right. And I have to really give props to the people who kept at it after a bunch of pretty dramatic failures. So that is an interesting story in medical history. If you're ever wanting to hear more about that, we can do that someday. All right, Sam, LDL 36, particle count 31, pattern B, small, yeah, particle data seems discordant from LDL-C. Is there any significance? So the particle data are more likely to be accurate, right? LDL-C is almost always a calculation, and the cholesterol is just the cargo, right? Your particles are actually the lipoproteins that we're measuring, and the lipoproteins are what cause trouble. So you may have heard me talk about this before, but the issue is sort of like cars, trucks on a highway. Cars and trucks all have a trunk or a passenger compartment or someplace where you can stick cargo. So you have, big semi trucks, you have Amazon Prime trucks, you have little motorcycles with the, little box on the back where they're carrying their backpack or whatever for the day. And so your particles are the engines, right? They're the vehicles that are driving around. How much cargo they have really doesn't impact the likelihood of you getting into an accident. Your likelihood of getting into an accident on a highway has everything to do with how many cars and vehicles are on that highway at the moment, not what they have in the trunk, right? You don't know if the semi's compartment is full or empty. You have no idea if there are 4 people in the car next to you or 1 person in the car next to you. It doesn't really matter. Your odds of being in an accident are related to the number of cars on the road. Lipoproteins are the same way. The amount of cargo each of them is carrying, that's the cholesterol. That's what we're measuring. That's the C in LDL-C, HDL-C. The cholesterol is the same, by the way, in all of those things. HDL cholesterol is the same as LDL cholesterol. What makes the difference in how these particles behave is the protein piece, the lipoprotein. Why is there lipoprotein? Because cholesterol is fatty and it's not soluble in water. So we can't transport fats around the body just by themselves. They have to be stuck on a protein to be able to move in our water-based body. So the lipoproteins are the more relevant piece. And I would say, typically if you're seeing discordance, it's because you have small particles and they don't have a lot of cargo. But if you have more small particles, that's not optimal and probably worth digging into a little bit more. Ryan, 75, 50-year-old male, 70 pounds overweight, CIMT and full cardio panel recently, 30% mixed plaque, LPA, A1C, ApoB, cardio risk recommended, rosuvastatin. So I don't know what the 30% means, but it's a A1C of 5.9 suggests metabolic syndrome, or certainly insulin resistance, right? That is pre-diabetes. 5.7 would be the cutoff for pre-diabetes. So an A1C of 5.9 suggests that there's absolutely some metabolic stuff underlying your plaque formation. So that is probably the first target I would have. Rosuvastatin is not wrong. Rosuvastatin may harm your insulin sensitivity. At 5 milligrams, it's unlikely to have a great big impact, but I would start with your insulin resistance first, and you can do them at the same time, but your lipid panel is going to be impacted by your triglycerides, which is mostly related to the insulin resistance part of this problem, not so much the LDL-C part of this problem. So all of this to say, work on that. Then we can think about your lipids. I don't see a number here for your Lp(a). I don't know whether that's elevated or not. If that's elevated, then you may have a lower ApoB target than the average bear. That's fine. We can think about that too. But I would say in terms of what is yours to control, first and foremost, would be the insulin resistance, your prediabetes. Cardiac rehab is the best investment ever. Oh, got it. LPA was 11. So that's not a huge contributor for you. Perfect. What does it mean? Mild decreased perfusion mid-right temporal lobe. It means that there is less blood flow getting to the right side of your brain on the particular moment they took that picture. What that means for your blood vessels, for your brain, kind of unclear without a little bit more information on that. All right, Andy Billy, LDL of 107, ApoB of 77, seeing high LDL and desirable ApoB. Is this inconsistent? So LDL-C and ApoB, I'm smiling because we are going to talk a lot about this in an upcoming video. I have a similar pattern in my lipid panel, and this is worth explaining, but it's also worth explaining twice. So we'll go into it a little bit here. Again, ApoB is measuring all of the different cars, trucks, and vehicles on the road that are delivering lipoproteins and cholesterol to the artery wall. Everything that is going to create, if you think there's any relevance at all to lipids in plaque, ApoB particles are the ones that are related to this. And so ApoB is a summary measure. It is the LDL particles. It's also the VLDL, the IDL particles, your triglycerides. Every of those proteins has an ApoB molecule or tag on it. So these are all of the different vehicles that are going to contribute to plaque formation. The LDL-C part are just the amount of cargo in like just the Amazon Prime trucks. So it's an interesting proxy measure. It's less helpful than ApoB. It's less helpful than the small dense particles. It's less helpful than oxidized LDL. All of it is still probably in some kind of relevant. How relevant related to insulin resistance or LPIR or inflammation or all of these other things, right? That's another conversation. But ApoB is the best measure that we have. So if you are discordant favorably for ApoB, what does that mean? It means like your ApoB is in the optimal range, but your LDL-C is high. It means you have fewer cars and trucks, but they just have more cargo in them. So Amazon Prime trucks are chock-a-block full, and that's cool because, again, just because they're full doesn't make them more likely to cause an accident, right? You don't have that issue. You have a decent, average, not terrible traffic situation on your highways. They happen to be carrying a lot of cargo, but that's not a bad thing. So if you're discordant, you would like to be discordant in this direction. Does that mean there's anything wrong? No. Is this a lab error? No. This is just the difference between measuring the ApoB particles themselves versus the cargo that they're carrying. Is glucose by itself inflammatory? Insulin. How much CVD do type 1 diabetics have? So small amounts of glucose and small amounts of insulin are not inherently inflammatory. There are absolutely problems when levels get too high, right? Hyperinsulinemia, hyperglycemia are inflammatory states and will damage the glycocalyx and will cause stiffening of the arterial system. And type 1 diabetics, especially early in the advent of insulin, were dying right and left of cardiac disease. So the hyperinsulinemia is absolutely a problem. And giving people a crap ton of insulin just to manage hyperglycemia, you can manage the glycemia, but the hyperinsulinemia that is the result of that strategy is absolutely problematic. So this is definitely an issue. I see a lot of type 1 diabetics with premature disease in the kidney arteries, in the leg arteries. They end up on dialysis, they end up going blind, they end up with limb loss, heart attacks, strokes, the whole shebang. And it is, people say it's related to glycemic control, but it's actually, especially for type 1s, right? That is lockstep in with the amount of insulin that they're taking to achieve their glycemic control. So those who are better controlled and using less insulin will largely do better than those who achieve reasonable control. But once you're on that roller coaster of high glucose, then high insulin, then low sugar, then supplementing glucose to recover, then going back on that roller coaster, right? Yeah, it's harder to get good glycemic control when you're swinging all over the place and you're using a lot more insulin. So at physiologic levels, I think if we were in an energy poor environment, which was sort of evolutionarily our norm, right? We walked around a little bit food insecure, then, small amounts of glucose were not that toxic to us, not that inflammatory. It was hard to get a lot of glucose, right? You got fruit in season and not, or maybe some milk if you had cows or goats or sheep or something nearby, but it was not easy actually to get an enormous glucose load from an evolutionary standpoint in a target-rich environment where we are today. Sorry, donut, with a lot of donuts and things that make it easy to have much more glucose and much more insulin circulating than I think our bodies were ever meant for chronically. I do believe that that becomes a pro-inflammatory state for very many people. All right, Michael, regarding high LPA, when would I recommend a CAC versus cardiac CT with AI? 51 years old, normal blood and metabolic markers, but high Lp(a). I've only had a CAC. Depends a little bit on what you would do differently with the information and if your CAC was 0. So if your CAC was 0 and there is more that you would be willing to do, like medication, supplements, changes in lifestyle, to reduce your cardiac risk even further, then a CT angiogram of your coronaries with plaque analysis might be worthwhile. You may also want that as a baseline to follow going forward in case you are choosing not to be medicated for your high Lp(a). It depends a little bit on how high your Lp(a) is. It is actually, we say it's high or not, but there are levels of high. There's a little high and then there's sky high. And there is risk association with sky high for, much higher risk than if it's merely high. So all that is relevant for you The cost will be relevant for you. It will not be covered by insurance to get a CCTA, but with the LPA lowering drugs probably on the horizon in the next 6 to 12 months, maybe that's worthwhile for you. Unclear how that moves the needle. It's not a recommendation yet. If your CAC is 0, you do have something of a little bit of a warranty. How long? I don't know. If it were me, I'd repeat it every 2 to 3 years. But if you are living with high Lp(a), then you may want more information. All right. What else do we have in our anonymous questions here? After duplex ultrasound carotid bilateral with the impression of the results being minimal atherosclerotic plaque at the bilateral carotid bulbs. So the bulb is where the common carotid splits into the internal that feeds the neck and face, and the internal which feeds the brain and the external which feeds the neck and face. The bulb, because there is more turbulent flow there, tends to be where we see plaque form early. No hemodynamically significant stenosis. So minimal atherosclerotic plaque says maybe they see some. It's a little hard for me to know without looking at the pictures. If you are interested in being maximally aware of your plaque status, yes, I think a CIMT to follow that would be a good choice. Do I feel 1 egg a day is risky for a controlled diabetic and an otherwise healthy diet? Generally, I think eggs are a superfood and people can consume up to a couple a day without too much trouble. If you are a hyperabsorber of lipids and lipids are a problem and you have plaque, you could consider removing eggs and seeing if it makes any difference whatsoever in your lipid panel. I personally love eggs and eat a couple a day and do not plan on giving that up anytime in the near future, but your mileage may vary. You will probably hear different perspectives from some of the sort of lower fat, more plant forward folks on that. And it is possible that it could make a difference in your lipid panel, but I would proceed with data. I would stop it and check and see if it makes any difference for you. Generally speaking, I think eggs are a good idea. Okay. What do I think of a postmenopausal woman, recent cardiac event, significant family history, who has been on hormone replacement therapy, HRT, for 5 years with oral estradiol, then with a patch? Now, an OBGYN advises to stop HRT due to cardiovascular disease and having a 5 to 6 year limit. Is this a valid concern, or new studies not showing correlation with HRT and heart issues? Okay. So, Women's Health Initiative came out in 2002 and said women should not be on hormone replacement therapy post-menopause because it causes heart attacks and strokes. And we have been climbing back up this hill for 20 years to try to figure out what exactly happened in WHI and does it have any relevance for modern menopausal care. The short answer to this very interesting and lovely question that I'm passionate about is I don't think that there should be any time limit on hormone replacement therapy. The risk in Women's Health Initiative was all incurred in the first year of treatment. These were also, by the way, women who were on average 10 years into menopause already. They were high cardiac risk patients recruited intentionally to have a high rate of events so they could tell if hormones would prevent it or not. That's how the trial was designed. And so after the first year of therapy, there was actually a trend towards protection. So if you had been, this person who asked this question has been on estrogen therapy for several years, you've already incurred the risk. And you were switched from oral to a patch or transdermal estradiol, which I think both are actually quite safe in average risk patients. For higher risk patients, including people who have had cardiovascular events, probably a patch or a transdermal form of estradiol is a slightly bit safer, but there's been no evidence that estradiol specifically or transdermal estradiol has anything to do with cardiovascular events. I believe that the estrogen receptors that we have on the inside of our blood vessels in our brains, if you don't see estrogen for a prolonged period of time, call it 5 to 10 years, those receptors probably go away, right? Why would the body maintain a receptor for a hormone that is really no longer circulating in adequate quantities to be a good signaling molecule anymore? The receptors probably just go away, and we lose the ability to upregulate them after a certain period of time. What is the magic number? Nobody quite knows. But for people who started hormones shortly after the menopause transition, call that within a year or two, right? You should still have plenty of estrogen receptors working. And again, all the risk that was incurred in WHI was largely in the first year of therapy. So you've passed that. Also the risk of plaque rupture was probably elevated because of the specific kind of estrogen they used for WHI, which was conjugated equine estrogen, or CEE. Premarin, which was derived from pregnant mare's urine, has at least 17 different varieties of estrogen in there, several of which are not native to humans. And CEE is pro-inflammatory. It increases a molecule called matrix metalloproteinase 9, or MMP9, which weakens the fibrous cap that sits over top of these ugly, soft, lipid-rich plaques. So MMP9 goes up with CEE. The MMP9 chews away that fibrous cap over the plaque, and you get plaque rupture events in the first year. So I would not recommend being a woman in your 60s who's been off HRT for 10 years and having no symptoms and then starting on Premarin. That seems like not a great idea. If you've already been on therapy for a number of years, you're on the safest therapy we know of, which is transdermal estradiol, where the 5 to 6 year time window comes from, nobody knows. The current guidelines from NAMS, from ACOG, still say the lowest dose for the shortest time possible. So that is what the guidelines say. Is there evidence that if we stop it earlier, you'll have less harm? No. There's some evidence that if we stop it earlier, you'll have less bone protection. Estrogen is approved, by the way, for the prevention of osteoporosis. So that's kind of neat. And if you stop taking it, you will lose that protection. That would kind of stink. So in my patients, we can certainly have the conversation about what the guidelines say versus how you feel on your hormones versus off of them. In my personal practice, I would not advise a patient to stop hormone replacement therapy if they have been stable for a number of years on a safe transdermal estradiol-based therapy. But I would acknowledge that there are many people in the cardiovascular space who would disagree with me. They have a different interpretation of the literature. I acknowledge I don't know everything. It's very possible that I am wrong. Obviously, I don't think so. And I have a OBGYN of 40 years who's actually written the paper on women's hormone replacement therapy. She is a mentor and a family member and my mother. So I get a lot of really great perspective from her on these issues. And she would not advise a patient like that to stop HRT either. But we recognize that that is not a uniform perspective in the medical community these days. Okay, moving on. Let's keep going. What do we got here? Hi, Stoker. Alphin waves, great cholesterol numbers, but LPA is 175 nanomoles per liter. CIMT shows vascular age as 6 years older than bio age. Fasting insulin is 8. BP 124/78, hs-CRP is fine. Glucose is great. Have no idea how to eat. Ideas. So a fasting insulin of 8 is a little higher than I'd like to see it. Not sure if you have any evidence of overweight or visceral adiposity, but those would be other things to think about. You are not really going to move the needle on your Lp(a) with nutrition. Like that will vary a little, give or take, but nutrition doesn't move that needle a lot. Almost nothing we have moves that needle very much, including exercise. Much of our pharmacotherapy doesn't move the needle. PCSK9s will. Again, there will be targeted drugs for this out someday soon. But what I would do is figure out what is causing you to have a little bit of hyperinsulinemia and where your excess energy is coming from and how you would like to manage that. So I would start with a food log and take that to somebody who can help you work through that and figure out whether you have excess energy, excess carbohydrates, excess fat that may be causing insulin resistance. Both, by the way, excess fat, excess carbs can cause insulin resistance. How you choose to manage it depends a lot on your personal preferences, what works for you in terms of food styles, and any other considerations in your life, other medical conditions, other things that work for you or don't. So I have no idea how to tell you to eat other than to make the observation that in my practice, a fasting insulin of 8 is a little high, and I would work on trying to get that down and keep monitoring for the CIMT and the arterial age. Something is driving that, and if I had to guess, I would probably guess the insulin resistance, but not sure. You could also double check a homocysteine and make sure that's not driving that uric acid as well, would be reasonable. Michael Evans, CAC was 3,291. Did you set a record? I don't know. It's certainly in the top 10% of scores I have seen, but it's I don't think it's the highest. I think I have seen higher than that. But yeah, I mean, if you can apply for a record somewhere, I think that's probably fine. Let's see. Hey, David. Thank you for coming. Thanks for dropping in. I really appreciate your support. Appreciate the low carb cardiology support here. All right. Paul, you are not late. You are welcome. Thank you for joining. We are all still having a good time and hanging out. All right. Hey, Sunshine. Andy Billy, how does the daily 81 milligram aspirin recommended by Bale-Doneen provider help? Is it about reducing plaque, or is it about preventing a clot from forming when a plaque breaks off? Andy, it's the latter. I'm actually super glad you have a Bale-Doneen provider. That's cool. I am also Bale-Doneen certified, and we can talk more about that if people have questions. It is a philosophy on root cause management of atherosclerosis and trying to figure out why people have plaque and how to address it. Aspirin for people who have plaque is intended to prevent the sticky platelet aggregation if and when there are these little micro rupture events in plaque walls. So that is the purpose of aspirin. Some people with elevated lipoprotein little a also take aspirin. If that is something that you are working on, that may be the indication. That's a little softer, but some studies have shown some risk reduction in patients who have elevated LP little a who take aspirin. I think that is in my second LPA video. You can go check that out and see if I have that. Alicia, I notice you don't recommend L-arginine as a supplement. Why? So L-arginine would contribute potentially for nitric oxide. It came up in some of the functional medicine stuff that I looked at for a while. I don't know how strong the evidence is for it, truthfully, in moving the needle for plaque. I don't think it's a bad idea. There was also sometimes competition for arginine and citrulline. So some people supplement both, some people just recommend one. I found it confusing and not as compelling as a lot of the other things that we've already mentioned. So is it bad? Probably not. Does it move the needle a lot? I don't know. If I were going to recommend it, it would certainly be in the context of ADMA and trying to drive nitric oxide very specifically. And I've had a couple of patients with elevated ADMA who've been on it, and it hasn't really helped. So I'm not totally convinced, but I'm open to hearing more about that if it's something that's worked really well for you. All right. What else? Amit, are 20 cigarettes bad for me? Like 20 a day, 20 in a lifetime? Cigarettes are bad for you. And if you've already smoked 20 in your lifetime and you're not smoking anymore, that's probably okay. You at some point could probably stand to be screened for abdominal aortic aneurysm. Usually it's 100 cigarettes would be the cutoff threshold for that. But, you know, is it the worst thing you've ever done in your life? Probably not, but I would not recommend 20 a day. That's a pack a day. That's not great. And less is better. Less is better on that front. Is ApoB 100 plus ApoB 48? Good question. I think it's usually just ApoB 100. And so now you're going to say, well, then you're not really measuring the triglycerides. That's accurate. Fair enough. Tommy, can I do telehealth in Florida? Technically, yes. I have a permit for telemedicine in Florida. What I will say about my CoreSight practice, and for any of you who have reached out to me about CoreSight, you will figure this out already. We are not up to speed yet. I am still figuring out all of the logistics of how to bring patients into this practice. I'm still working on getting all of my forms and registration stuff done. And it has been a very slow and painful process. So I am building the wait list. But yes, I can technically see patients for telemedicine in Florida. We are not ready to open those doors quite yet, but I am hoping someday soon we will be there. The caveat is going to be that if you are Medicare or Medicare eligible, I cannot see you through CoreSight. You're going to have to come to Scripps for that. That is a very complicated situation, but long story short, if you are Medicare eligible, I cannot see you through CoreSight, even though I have a license. All right. Can potassium deficiency cause arterial calcium buildup? I am not convinced that a potassium deficiency is a good idea. I don't know how many people just run around deficient in potassium at any given time. Anyway, the body regulates that super, super tightly. What I will say is that low potassium levels may be associated with high blood pressure, and that will potentially cause issues with arterial calcium. So that's probably where I would go with that. Beyond that, I'm not deeply familiar with that. The Lord is pretty disgusted after having to watch his creatures hump away on each other for the last 4,000 years. Okay, neat. What is a mild calcified aortic root? So this is calcium around the annulus or the outer wall of where the aortic valve sits. It may eventually creep into aortic valvular calcification, but it is the very, very start of the aorta where the valve sits. So there's been calcium deposition there, and that is potentially age-related. It's potentially also Lp(a) related, and I would investigate further on that front. Yes, Paul, WHI also used synthetic progestins, which are also pro-inflammatory and prothrombotic, meaning likely to create clots. So the synthetic progestins also had issues, but even the CE alone arm had some issues. All right. Could I explain why the new oral cholesterol drug was improved without long-term outcome data, but LPA drugs have not been approved yet? This has much more to do with how the FDA is requiring trials to be designed and what the trials are actually doing, whether that is really been different between the LPA drugs and the PCSK9 drugs. I don't know. Certainly the oral PCSK9 drug is the same target as the injectable PCSK9 drugs, which we do have outcome data for. So mechanism of action is the same. It is simply a different mechanism of delivery, right? So we know that the PCSK9 drugs work. We know that they reduce events. We know that they have some impact on mortality, at least cardiovascular related mortality. And for that reason, I think that the path for enlicitide was probably a little more straightforward. LPA is first in class. We don't have any data yet on that class of medications. And so I think those trials are going to be a little bit more involved. And that's why we're waiting a bit longer to see those drugs come out. Nitric oxide is released by UVA light. Tell people to get outside. Get outside. It's good for all of us. What is the one lipid marker that would be taking a statin no matter the other variables? Would I recommend, based on a lab value alone, to take a statin independent of any other variables? I'm not sure I'm willing to say that. If I were going to pick one, probably the small LDL particles, if I had to like really commit to that, but I would almost never treat somebody in like as a number in isolation. I hate that. I think it's reductionist and doesn't serve people. But if you were going to pick something in a lipid panel to really focus on, that's probably that, or oxidized LDL are probably the two that are like the most strongly correlated with ASCVD, for which statins would actually be relevant. But I'm not sure I would do that without any other issues. Any way to predict what killed Lindsey Graham, an aortic tear, other than chronic hypertension? So aortic dissection. is what killed Lindsey Graham. This is a tear in the wall of the aorta. It can happen close to the heart, which is called a type A dissection. It can happen further out in the aorta, like chest or further down. That's a type B dissection. That's actually old terminology now, but for your purposes, it is the most helpful, I think. And high blood pressure is the most common risk factor for this. People who, we mentioned this earlier, people who have weakness in the blood vessels from connective tissue disease like Loeys-Dietz syndrome, Ehlers-Danlos syndrome, vascular Ehlers-Danlos to be very specific, Marfan's, those patients are also potentially at increased risk for dissections and aneurysms. But beyond that, no, not really. It is a difficult thing to diagnose. They happen very quickly. And the ones that are close to the heart are the ones that are the most likely to be fatal in rapid succession. How many hours of nitric oxide should be produced in 24 hours? I have no idea. I have absolutely no idea. Okay, let us go back to our anonymous questions and see what else we have here. When do I get concerned with hs-CRP? It was, this person says 10, then down to 6.5 3 weeks later, usually around 2.5. History of temporal arteritis, LPA of 160, 20 milligrams daily of rosuvastatin. Recently diagnosed high blood pressure. 92-year-old woman with excellent mobility and cognitive functions. PCP is not concerned. Do I suggest any other tests to figure out the higher hs-CRP? What do I think about adding low-dose colchicine? So I get concerned with hs-CRP over 3 chronically, as this came up in a couple of other comments from a recent video. hs-CRP can be very elevated with a recent infection or illness, so don't check it after anything like that. Check it in your normal state of health. And if it's elevated, check another one 2 weeks later. That is kind of the general recommendation for hs-CRP. Glyc-A might be an alternative. In a 92-year-old, I wouldn't check it again no matter what. It's going to be an issue about chronic disease and plaque progression. And at 92, don't worry about it. Unless they are complaining of symptoms related to either temporal arteritis, giant cell arteritis, arthritis, something else, then maybe low-dose colchicine would be helpful. Colchicine, through the LoDoCo trials, has now been approved for prevention of cardiovascular disease related to elevated inflammation. It does reduce major adverse cardiac events. The impact on all-cause mortality is a little disappointing. We don't really have a signal that it improves all-cause mortality. And canakinumab was the monoclonal antibody or the immune-related drug that was actually tested also for cardiac prevention. It knocked down interleukin-1 beta, which is one of the signaling molecules in our immune system, and it did a bang-up job of reducing cardiac events, but it increased fatal infections. So the total effect on mortality was null. It was going to cost like $150,000 a year, and they canned the drug because it fixed one problem and caused another one. So I think addressing inflammation by suppressing the immune system is a short-term win, maybe, but I don't prescribe a lot of low-dose colchicine for this reason. I really, if we go down the rabbit hole, periodontal disease is one particular reason to have elevated hs-CRP. An occult abscess in the mouth, typically around a root canal that's asymptomatic, maybe another one. I have heard of heavy metal toxicity causing it, although I've never diagnosed that myself. Visceral adiposity is typically reasons 1 through 3 in my practice why somebody might have an elevated hs-CRP that's persistent. And again, in a 92-year-old, I wouldn't mess with any of that. But in a 62-year-old, I would absolutely try to understand where it's coming from. You may not be able to figure it out, and at that point, you could consider low-dose colchicine if statins didn't do it. Statins are also potentially indicated for this reason. But yeah, I think that's not something I would go after in a 92-year-old. All right. If the #1 cause of death in America and worldwide is heart disease, why isn't everyone seeing a cardiologist at 25? Okay, let's step back from individual care for a second and let me put on my public health hat. The issues about preventive care and screening. So to screen for a disease, it has to be very prevalent in the world at large, which heart disease absolutely is. So that's an easy win for screening for cardiovascular disease. And the other thing is that if you find it early, you have to be able to do something about it to change the outcome. It also has to be cost effective, and it has to be widely available, and it has to not be dangerous. And there are a bunch of other sort of check boxes that something needs to meet to be worthwhile for screening. But the big bugaboo for heart disease has been our really like embarrassing inability to move the needle when we detect it early. There are now some studies, especially using CT-based technologies, that are showing some capacity to change people's risk for disease long term. Allscott was one example of this in patients who had angina, but overall, we've done a very disappointing job of managing cardiovascular disease. And people who argue against the lipid hypothesis would point that as reasons number 1 through 5, why that can't be the whole reason, right? If cholesterol were the only problem with heart disease, we could have solved this 30 years ago. The fact that we have all kinds of drugs that medicate ApoB and treat LDL-C and bring it down, and we still have a lot of residual risk, says that there's more to the story. Now, I don't think that that invalidates the role of ApoB for some people in their plaque. Other people disagree with me, no problem. But I do think wholeheartedly that ignoring the rest of the metabolic picture and focusing only on ApoB as like one causative factor will absolutely fail to reduce risks for cardiovascular disease. If you ignore the insulin resistance and the inflammation and the, poor health status and stress and social connection and lack of being outside and all of these other things, we will continue to fail to prevent progression of disease. And so if we detect it earlier, but don't do anything about it in terms of altering mortality, then we have not demonstrated that we can help. So what do we have to fix? We have to fix therapeutic inertia. What does that mean? This is when you go to your doctor's office and every year you have a blood pressure of 130 and they're like, it's not that bad. Work harder, eat less, move more, and we'll check it next year. You'll do better, but it's not that bad. We don't have to put you on medicine yet. Or you're on one medicine and you're, 132, and they're like, well, we could add another medicine, but why don't you just work harder, eat less, move more, and sleep better, and we'll check again next year. Therapeutic inertia is the inability to escalate therapy when there's clearly something wrong. This happens a lot. Blood pressure is the most common culprit here, but cholesterol, insulin resistance, overweight and obesity, all of these conditions, sleep apnea and disordered sleep, all of this is stuff that kind of comes up regularly in doctors' offices and doesn't get proactively managed. It's hard for a lot of reasons, and maybe that's another question for another time, but what I'll say is if we're going to fix this problem, we have to be a little bit more aggressive. In my practice, that means seeing people more often. It does not mean preventing them from trying to move the needle with exercise and nutrition, but it means checking in at 3 months or 1 month instead of 6 or 12. Because if it's not working, then we either need a different lifestyle strategy or we need to escalate therapy. Which of those we pick depends on how bad the problem and risks are and all of those things, right? But in my practice, I typically see people back much more frequently to have that higher touch point to make sure that we are not losing sight of these issues, and that if we are working on lifestyle issues that we're making progress. And if not, then we change the plan. But the issue with why everybody doesn't get checked at 25, why everybody doesn't see a cardiologist, first, I don't think that cardiologists want that. Most of them don't want a prevention practice. And secondly, as a discipline, we have foundationally failed, most of us, most of modern healthcare, to actually prevent this. We have kept people limping along with chronic disease, but we have done a terrible job of helping people reverse or put into remission their chronic disease, including atherosclerotic cardiovascular disease. It's here. Connect your health data securely to Apple Health ChatGPT. Is this bad news or good news? I don't know yet. I know that your data will absolutely be used to train the model, and that many of these companies are hiring docs to sort of help them sort out what's going on. I think whether AI is a huge help for us or not is going to largely depend on the training and the biases that are baked into the systems as we go forward. There was an interesting paper that came out recently. Those of you who follow me a lot will know that I have used open evidence as my large language model of choice for a lot of health-related things. We've gone through them on this channel. Open evidence was compared, and also there's a second one that's medical specific, was compared to Gemini, Claude, and ChatGPT, and scored on like both general knowledge questions, clinical scenarios, and there was one other thing. It was a pretty involved study, and then they had physician graders, and actually open evidence didn't win. And I was a little surprised by that. So this is an evolving space. I still think that the basis for open evidence is strong, meaning it's really well grounded in a lot of the scientific medical literature, but the medical literature isn't perfect. It is flawed and it is incomplete. There are other sources of data that are available. ChatGPT, Claude, Gemini, they are all working through different permutations. Some of this was about safety. Some of this was about the clarity of the response. Open evidence is intended for clinicians, so it's a little wordy and it's a little complex sometimes. I don't agree with everything that open evidence says or any of the large language models on health issues. So, and that's when I know what the answer I want it to be is. And I've asked it questions where I have a good sense of the priors. If I'm asking about something I don't know what the answer is going to be, I feel medium sure that I'm getting a good answer. But what is the alternative? The alternative is doing a literature search in PubMed, which is highly subject to bias, right? I'll find some papers depending on my search strategy, but there'll be others that I won't find. Could look it up in a textbook. If you've ever, medical textbooks are sort of an invitation club, right? The editor picks their friends or their people they trained with, or they like activate a network and they ask people to write a chapter. And the chapter is only as good and complete as the author whose job it is to do that. The chapter is largely recycled from the previous edition, right? Most textbooks have major editions that are redone every few years, unless it's the very first edition of a new textbook. Mostly the chapters are not written from scratch. They'll be updated, again, based on some literature search, may or may not be biased. All this is to say, a textbook chapter isn't perfect either. It is not necessarily a definitive authority on this particular question topic. It's likely to be accurate, but it may not be complete. So, and it might be out of date by now, right? Who knows how old the textbook is? No source of data is perfect. AI is going to help us process more, but the rules that are going to be used to derive how it makes decisions, how it engages with the person asking the question, all of this is very, very new and up and coming. So I don't know yet what is going to happen with AI in healthcare. The best case scenario I can imagine is that AI gets to do what computers do best and allows doctors to go back to being human. But that's a very optimistic scenario. And I can also imagine some very pessimistic ones that are not as ideal. So stay tuned. We'll see how that goes for all of us. 2 weeks prior to my CVD event, I had strong chest pains, no physical exertion. I lost my voice completely. It was the oddest thing ever. No one has mentioned what caused it. 2 weeks after the stent placement, my voice fully recovered. Ankle had swellings. Have I seen lost voice in other patients? I have not heard of that before, and I don't have a great explanation for why that might be the case. I am trying to think about the nerves that go to the voice box. Those are ones that I interact with quite often because they're in and around the arteries in the neck. One of them does go down around the aorta, but why that would be related to an ischemic event in the coronary circulation, I don't know. That's a stumper. I'll have to think about that one. Can I share my medical education, training, residency programs, board certifications, and fellowships so that people may know my qualifications for medical information and also how awesome I am? Thank you. So 4 years of undergrad. My undergraduate degree was in psychology and neuroscience. And then I had 4 years of medical school, which gets you the MD. Then you do a residency training, which is sort of like an apprentice-based model. The length of your residency depends on what you're training in. So the shortest ones, I think, are 3 years. The longest ones are 8 or 9. Mine was 7, 5 of which were clinical, 2 of which were research, and that was in general surgery. So I did that first. Then I did a 2-year fellowship in vascular surgery. And I also then I got board certified in general surgery. I got board certified in vascular surgery. Separately, I did some training and continuing medical education, and I'm also now board certified in obesity medicine, but did not actually do a formal clinical fellowship in that. But there is a pathway for board certification for obesity medicine that doesn't require that. And so that's how we got here. I will also say the vast majority of what I learned about prevention, about plaque, about all of this, like never was anything I learned in medical school or my residencies. All of this has been my own continuing medical education that I have done in my own time after the fact, because I needed to know more and I felt like I was not given the tools in my training to do what I wanted to do for patients. What my training gave me was the foundational vocabulary, the understanding of how the body works, and the technical skills to do the surgery that I perform, and how to take care of patients in the hospital. But I will say that 90% of what we talk about here is stuff I taught. I didn't teach it to myself. Other people taught it to me, but I sought out myself and went to go find smarter, better people to help educate me about a lot of these things. And my education is ongoing. It is imperfect. I say I don't know here quite a bit. And it always like gives me a little niggle. Like, I wish I knew everything to tell you guys. I wish I knew the literature on every single supplement you ask about and like the ins and outs of all of these different tests and things. And I'm not quite there yet. I am trying. I'm learning every day. It is the most fun that I have in my job right now, which is to learn things, work on them in my practice, help patients with them, and try to help teach you guys too. And so thank you for being with me on this journey. It has been remarkable and delightful to have this opportunity and platform to be able to share this all with you. All right. General formula of 120 minus AH to determine maximum heart rate for HIIT training. Is there a more specific way to determine a customized maximum heart rate? The only other one I have seen is to actually get the max effort and generate your true maximum heart rate and then work at a percentage of that for HIIT training, right? Most of the HIIT intervals are at a percentage of maximum heart rate. So the only other mechanism I have seen to derive that is to actually do an all-out effort and see what your max heart rate is. If you have ever done that or come close to it, it's not super fun. So that's all I have for you. I will say I have done it once or twice, and I think that I made it up to 187, which I was not terribly impressed with, but okay. Which is not that different from 120 minus age, but it's, and so, yeah, 120 minus age actually won't be your maximum. I think it's 180 minus age. If I had to, even that's not right. I'm missing something in that. I think that's your 80%. I'm not sure. This is devolving quickly. I'm not sure. We'll come back to it. I'll answer it in the comments later. All right. All right. Open evidence, trust but verify. Yes. George, have I seen the debate regarding PCSK9 inhibitors where research came out reanalyzing the raw data? and found that no CVD benefit and increased Repatha all-cause mortality. Yes, I have seen that, and it was one trial. We now have several trials. I have not seen sort of the complete meta-analysis of all of that, but I think it's worth looking into. The four-year trial is, I think, what you're referring to, and it was the raw data that showed more mortality in the intervention group than in the treatment group, but when adjusted, I believe it still was neutral. But you're right, there is some inconsistency there. I don't think that that was true for the other PCSK9 inhibitor trial that was out, but I may be mistaken on that. MW, how can A1C be high, 5.8, when fasted insulin is low? This is possible when your postprandial, meaning after eating, glucose and insulin spike. So I have seen a number of people who have low fasting insulin, but if you challenge them with an oral glucose tolerance test, which is where you drink a load of 75 grams of glucose and then measure your blood sugar and hopefully insulin at 60 and 120 minutes or 30, 60 and 120 minutes, you'll see a pretty dramatic spike, and insulin will probably rise disproportionately high to account for that. But it means your fasting levels aren't high yet. It's possible that the A1C is spurious, that there are some people who have elevated A1Cs that don't have high blood sugar. Why that is a little unclear. There are a lot of people who posit longer red blood cell lifespan will increase hemoglobin A1C, and that there are some ways of eating that might prolong this. And that's why, for example, carnivores tend to have elevated A1C. That's not really been substantiated. It's a nice theory, but I don't have a lot of proof or data for it. But all comers, my first instinct would be that you are having postprandial or after eating spikes in sugar and insulin that is driving the A1C, if in fact it's real. Best guess. All right. Statins are known to cause muscle damage. Is this only on voluntary muscle, or could it also affect cardiac muscle? So, Jason, statins can cause really severe muscle damage in a very, very small proportion of people. That is where you'll get elevated markers of something called creatine kinase or CK. We don't routinely check for that anymore, and most of the newer statins are not very likely to cause that. But the more insidious thing is whether there's low-level damage to the metabolic machinery within muscles, like the mitochondria, and is this something that happens? Maybe. Is that related to the muscle aches and pains that people get? Unclear. Maybe. It would, in fact, impact all muscle cells. So yeah, it could also impact the heart. Has there ever been any evidence that statins reduce heart function? No, not to my knowledge. But if you're worried about the impact of statins on muscle health, heart is a muscle, and there's no reason to believe it would be impacted separately than your skeletal or axial muscle. Again, I think that the statin muscle issue is dose dependent. I find that most patients are able to tolerate the low doses. Does that mean there's no impact? No. Does it mean I can promise you that you'll have the same muscle that you would have if you weren't on statins? No. I was not overly impressed at the paper that came out maybe 6 months ago that showed like muscle loss in people who were on statin therapy versus those who were not. I thought there was a huge amount of selection bias in the patient cohort for that study. So I didn't put a huge amount of stock in that. They said they controlled for all the confounders. I don't think that's likely, but I acknowledge that there is absolutely an impact of statins on the mitochondrial function. Some people will drop their CoQ10 levels. Some people have muscle symptoms. That is absolutely true. And in a perfect world, would we use statins? No, we would use other drugs if we could have access to them reliably, safely, and routinely. That is not the current world that we live in. And I do find that most of the impacts of statins can be mitigated with dosing, but they're not a perfect drug. They have side effects, especially for some people. And if that's the case, the best I can offer is to take people off of them as soon as I hear about side effects, and then move on and use that as a way to leverage insurance to provide the other molecules that are potentially less likely to cause those issues. All right. Doc, small dense LDL and oxidized LDL has not considered evidence or predict. Typical non-functional cardiologists don't believe on these two numbers. It's not useful to them. Yeah, they're not routinely tested. I get that. If you look at the large data sets, they are more predictive than LDL-C or ApoB. The argument from the lipidologists is that LDL-C is good enough. And so they have moved away from even ApoB testing in most people, and they are still just getting, they still really are just asking for everybody to get a fasted, regular old lipid panel and, you know, deal with the Friedewald equation for calculating LDL-C and hope for the best. And from their perspective, you know, as long as everybody's on LDL-C lowering drugs, that's good enough. And their take on it is that the side effect burden is low to minimal, and that as long as just you drive LDL-C down to targeted threshold values, that ApoB will be low enough and LDL, small dense LDL will drop and oxidized LDL will drop, and all of the bad things will just drop along with LDL-C. And if you just treat everybody and bring them down to that threshold, that's good enough. That is the prevailing philosophy among the lipidology community. And if there were truly no consequences to dropping LDL-C, then sure. But whether you do it with a lifestyle approach that involves a fair amount of dietary manipulation, whether you do it with pharmacology or supplementation, there is always a consequence. There is always a consequence to changing our physiology. Many people do absolutely fine. I have a large number of patients who do absolutely fine on lipid lowering therapy. And again, remember that I see a lot of people with plaque, right? As a surgeon, that is my basic population. So I don't see as many primary prevention people. Fewer of my primary prevention patients are on big doses of lipid lowering therapy. Some are not. All that is to say, you know, it's really a matter of philosophy. And if you want to be more precise about what you're really treating and how you're assessing risk, then more advanced testing can be helpful. If you are just trying to, you know, squash ASCVD at the population level, and then getting everybody to get tested and just suppressing everything is kind of the scorched earth approach. Again, I think we ignore the rest of the metabolic disaster that is befalling our country at our peril. I just saw something today that said that the rates of diabetes, type 2 diabetes in children is going up dramatically. And those people will become adults with early atherosclerosis. Even if you put rosuvastatin in the drinking water, they're likely going to develop atherosclerotic cardiovascular disease if we do not manage their metabolic derangement. So I just think that that philosophy is, it's not wrong, but it's incomplete. And we will continue to have unimpressive outcomes in cardiovascular mortality if we are not taking this bigger picture approach for everybody. Okay, yes. Is there a way to submit AMA questions in advance? Typically, if you're watching the shorts, I submit that form for the anonymous questions, and we put up the link for the live a few days early, and the chat is open at that point as well, so you can drop questions there. 220 minus age. Thank you, Paul. Thank you. I love it when you guys save me. All right. Beetroot powder, too much a problem. I don't know. I have never seen somebody overdose on beetroot powder. I suspect if you were a super responder to it, maybe it could drop your blood pressure a little too much, but I don't think so. Indian Canadian, welcome. My left and right carotid have 1.2 and 1.5 millimeter intima thickness. Does that mean my heart arteries also have plaque? How can I get this confirmed? Okay, 1.2 millimeters is thickened. 1.5 millimeters, at least in my lab, would be a plaque. So the difference between thickening and plaque is 1.2 versus 1.3. That's an arbitrary distinction, of course, but you have to draw it somewhere. So 1.5 millimeters is a small plaque. Does this mean my heart arteries also have plaque? It is not for sure, but it's about 90%. And the only way to know for sure would probably be to get a coronary angiogram to go looking for the soft, small plaques that might be in your heart arteries. But you can think of it as a disease that impacts every artery in the body. It is a systemic disease. It impacts everything. So if you know you have plaque in your carotids, I would personally assume that there is some that either is or will form in your heart arteries and manage your risks accordingly. You don't have a lot. 1.5 is not a huge plaque. It's a pretty tiny plaque, but it's an opportunity to figure out what's going on, get on top of that, and try to get that nipped in the bud before it ever grows or becomes a real problem. So if you wanted to know about the heart arteries in particular, you'll have to get a dedicated scan for that. With that degree of disease burden, you're probably going to be looking at a CT angio, not just a calcium score. And it might be negative, right? Again, you may be in the small percentage of people who have it in one artery bed, but not the other. Again, it's not perfectly concordant, but it's about 90% overall that if you have it in one, you'll find it in the other. All right. Hey, Feldman Protocol, welcome. Q&A on a Saturday. That's right. All right. Do I have an opinion on lipophilic versus hydrophilic statins? Rosuvastatin in general, if I'm going to use one, is my preference over atorva. I don't even use Simva anymore. Pravastatin, pitavastatin, the latest I have heard from your friendly lipidologist, Tom Dayspring, is that we think probably all of them cross the blood-brain barrier to some extent if used long enough. No, I don't know how to substantiate that. I find that the water soluble ones just seem to be ones that I can adjust dosing on and seem to be a little more forgiving in terms of side effect profiles. The couple of case reports for desmosterol suppression and brain fog were, I think, related to the fat soluble statins. And so in general, if I'm going to start one, I prefer a water soluble, but it's not clear to me that there's actually a lot of data to support that bias or that preference. It's just the my personal bugaboo. Yeah. Which kind of statin is less likely to cause muscle pain? Nobody knows for sure. What I can tell you, the higher intensity statins and the higher doses will be most likely to cause side effects of any kind. The lower the dose, the less likely that is. And so the other thing you'll hear online is that if you have side effects on one, you should try a different one. That is correct. Many people will say if you have it on either of the two that are eligible for high intensity statin therapy, that would be rosuvastatin or Crestor, and atorvastatin or Lipitor, then go back down to a low intensity statin like pravastatin or pitavastatin, and you may not have myalgias on those. That is also true. They will also be less effective at lowering your ApoB, but if you're struggling and unable to tolerate the moderate intensities, then so be it, right? You do what you got to do. Personally, at this point, if I have patients who fail Crestor and Lipitor, I try to move on to either bempedoic acid or inclisiran or PCSK9 inhibitors at that point. I just find that most of my patients who have severe plaque and disease are not going to get quite enough lowering on pitavastatin or pravastatin, even with Zetia. But you can try them, absolutely. And if you tolerate them, so be it. But they will not count as even usually moderate intensity statin therapy, and you're probably not going to get sufficient LDL lowering for that. Paul Elkins responding, D-dimer, clot breakdown. If D-dimer is high, that means there is clotting occurring. Yeah, D-dimer is an interesting screening test. It is supposed to test for the presence of clotting. It will also be elevated in acute inflammatory states, and so it's not a perfect test. It is a nice screening test for blood clots in people who have not had surgery recently or things like that. But for example, a patient who has a knee replaced, their D-dimer will be elevated for 6 weeks after their knee replacement. So you can't even use it for screening for a DVT in a postoperative patient at that point. So it's a decent marker for people who are not acutely inflamed. It is not a perfect marker that way. Do I think if and when new LPA drugs are approved, they will also lower LDL-P and eliminate the need to also take statins? Probably not. They are very specific to the lipoprotein a molecule, intentionally so. So I think they were not there. So the LDL-P may also be capturing some of the LP(a), so you might see some drop, but it's not going to be dramatic unless you have sky high LP(a) levels that are accounting for some of your LDL particles in your NMR analysis. Thoughts on the clearly coronary CT scan? So I had you said CAT scan in your comment. I'm laughing because I had a faculty member in my training who, if you said CAT scan instead of CT scan, would throw a hissy fit and ask what the name of the cat was that was in the scanner. It's a CT scan, not a CAT scan. Everybody says CAT, it's fine. But I'm just like remembering trauma from my training. The concept of AI analysis of plaque is very interesting, and I like it a lot. The two companies that are available to provide that commercially right now are HeartFlow and Clearly. Both of them have a plaque analysis tool, which is a computer-based AI overlay to your CT angiogram. So you can get a CT angiogram of your coronaries done anywhere, send your CD into either of those companies, and you will get a very pretty report showing you your total plaque volume, your non-calcified plaque volume, your calcified plaque volume, your low attenuation, which is the very lipid-rich, kind of scary, vulnerable plaque volume, and all of these things. What are the major underlying issues? I think that there are a few. The first is that all of these tools are still in evolution, and we are unsure how the algorithms are changing month to month, year to year, but the resolution of these scans is not perfect. So you can probably get down to sub-millimeter resolution, maybe. But once you start having calcium and blooming artifacts and other things, how the algorithm is drawing the line between the vessel wall and the surrounding soft tissue and the calcified plaque versus the non-calcified plaque versus the contrast, like all of these are very technical issues, but they speak to the reliability, repeatability of these tools and how much we believe the precision of the estimate. So you'll get a specific number, right? Just like you get a specific number for the CIMT. I know based on Todd Eldridge's work through his cardio risk protocols, his testing, and his validation that the CIMT test that I'm doing is accurate to 0.02 of a millimeter. I don't know what that number is for the AI plaque analysis. Is it a millimeter of plaque volume, cubic millimeter? Is it 10 cubic millimeters? Like, what is the spread? If I send them the same CT scan 10 times and they think it's a different scan every time, but it's not, it's the same one. How different are the answers that I get from them every time? I don't have a sense about that. And so I don't know what it means to send somebody for another one 2 years from now. How much detectable change can we get? What is real? What is noise? We don't know those yet. And I think that this is an issue with the technology in general and perhaps one of the companies in particular, but the moral of the story is I think it's a great baseline test to understand, do you have soft plaque or not, right? It's a very good test to answer that question, yes or no. I believe pretty confidently that we can answer that. And I think you can probably detect big change in non-calcified plaque volume, right? A doubling or a halving if you were experiencing regression. Like maybe that's real, but I think it's a premature to put people on a, every 3 to 5 year path and think that the technology that we have 3 years from now to analyze these scans is going to be the same. And if you are using the old algorithm from the scan for your baseline and the new algorithm at 3 years, are they comparable? Are you going to run the old one again on the new algorithm? These are just a lot of unanswered questions I have. To be fair, I haven't sat down with anybody from these companies. They may have some answers to these, but I don't know what they are. They're not really transparent about advertising them. So I have sent scans in. I have talked to their reps and the people who show up at conferences and like try to sell you the stuff, right? I've talked to those people. They're big on promises, light on data. So it's a really promising technology. I think it's very exciting. There are a lot of other people in the space trying to figure out how we can get the best, most reliable imaging. CT is probably, as much as I love ultrasound, There are a lot of limitations to ultrasound, including just the throughput, right? Having the number of people to do the scans that are probably going to limit it. And the cardiologists who really run this space, much as I'm loath to admit that as a poor little piddly vascular surgeon, the cardiologists want heart pictures, right? Everybody wants the organ that they work on. So for those reasons, I think CT imaging of the heart is going to be the dominant technology going forward. These AI tools are not going anywhere. They are coming with us. So it's only a matter of time before we get more granular information about how precise and useful they are, especially in a repeated setting. For now, it's a great baseline test. Should we use it serially? Probably eventually, but I just don't have a lot of understanding yet of just how much precision we have in the data. But there's a lot of good that comes from it. You can also get information on something called fractional flow reserve, FFR, which will help you understand how narrowed is the artery. Is it causing significant stenosis or ischemia downstream? Is the heart muscle asking for more oxygen than it's getting? That's a cool, interesting technology that is available now. Understanding where your plaque is, which of the arteries, that is useful information that comes from these overlay technologies. So, all of my concerns aside, I do think they provide a lot of additional information and are probably worth doing at least once. Going forward, as it matures, we'll get better at it, and I think we'll be using them more and more. I still think it's early days. Thoughts on colchicine to lower inflammation, very high hs-CRP, some elevation of uric acid, salt and calcified plaque from CCTA. So Jack, I mentioned this earlier, colchicine will lower your inflammation. It does not reduce all-cause mortality. And I would like to know why you are inflamed. What is the origin of your elevated hs-CRP? Is it visceral adiposity? Is it something in the mouth? Is it the uric acid, which I don't know how much elevation a little is, but that might be an issue for you. And I would work on getting that down. Is it insulin resistance and hyperinsulinemia? Where is that coming from? Like, let's try to see if we can figure out the root cause and get that under control before we just suppress the immune system. Your immune system is trying to do something for you, right? It's just trying to solve a problem. And if you don't understand what the problem is, you're just squashing the firemen, right? Like these hs-CRP, right? It's the firemen showing up to like put the burning house flames out. And you're just like squashing the firemen without understanding why the house is on fire. So there are, as I said, some people for whom we just don't understand why the hs-CRP is persistently elevated despite a, several $1,000 workup, but it's the minority. Most of the time we're able to kind of figure out what's going on and why. And as I said, in my practice, it's often 1 through 5 is visceral adiposity. So that's where I would probably start, not knowing anything else about you. Stuff in the mouth is number 2, periodontal disease or an occult abscess over a root canal. You might need a cone beam CT to find that. Periodontal pathogen testing, if you're really going down a rabbit hole, might be worthwhile. Heavy metal testing is something I have heard of in other practices. I personally have not diagnosed it, but I have heard at least one other practitioner who found the source of inflammation that way. Do I understand this correctly, that statins treat the symptoms and do not treat or fix the problem? Christian, this is a very interesting question. Statins don't treat symptoms at all. There is no symptom of heart disease short of the heart attack or stroke. They are one component, right? They are managing lipoprotein volume, which are, again, these proteins that traffic the cholesterol and fats in our blood because they don't float in water. And that, in my opinion, is relevant for some people with atherosclerosis or plaque in the arteries. It is very rarely the only thing wrong. It is very rarely the only problem, and it's probably the least important problem in many of my patients. The insulin resistance and inflammation seem to be a much more common, bigger issue for many things. That being said, I still manage elevated ApoB levels in patients of mine who have plaque because I think it's part of a multifaceted strategy to help manage this disease process. Do you have to be on it forever? No. But especially in a general all-comers population, is there evidence that managing ApoB, at least in part, can reduce adverse cardiac events, meaning heart attacks, strokes, and limb loss? Yes, there is. And is there evidence that it might actually improve all-cause mortality in some of those patients? Yes, there is. So there are reasons to consider using it. And it is certainly not the only thing, right? There is no scenario in which I give somebody a lipid lowering medication and I'm like, bye, see you later. That's all you need from me. Never, like almost never, maybe never, actually never. Judges much love Dr. Lilly when she testifies. I have actually not testified in court yet, so I don't have an answer for you on that one, Donut. #1 bestseller. Someday, maybe someday. Chasing Clean Air, 66-year-old female athletic, LDL's 174, mostly plant-based. PCP says statin. Would I base that decision on LDL alone? CAC scan. Yeah, at 66, I think a CAC is a reasonable place to start. If you have access to either a CIMT or a CCTA, that would be max information, and that would usually be better. But the best test is a picture test, and the best picture test is the one you can actually get. So I advise a telemedicine company that does women's telemedicine across 50 states. Most of those patients are almost entirely dependent on insurance. They don't have cash. They're not really going to be able to go out and get a CT angio or even a CIMT. And so for almost all of those patients who come in with severely disordered cardiometabolic issues, CAC is what I recommend. It's a place to start. And at 66, there's a decent chance that if you have a problem related to your disease, it would show up. It does not mean if your CAC is 0 that you don't have plaque. And that is the caveat to that particular test and choice. It is reasonably reassuring in the short term that that's not going to be an issue, but there is somebody in the audience who has had a CAC of 0 and went on to have an event. So again, it is not a perfect warranty. It is a reasonably good bet, but you know, your mileage may vary. With triglycerides of 120, I wonder where that's coming from. If that's fasted, and your HDL at 39 is a little low, trigs are a little high. Your A1C is normal, but I would be curious what your fasting insulin is. Be curious if there's a component of insulin resistance. You could ask for an LPIR score on an advanced lipid panel. For people who are asking, like, why would you do particle testing earlier? Getting an LPIR score is actually one good reason to think about getting advanced lipid testing, because it's interesting. LPIR is a measure of insulin resistance, just like HOMA-IR and fasting insulin. I find that they are not that concordant. I can see a normal LPIR and a very elevated fasting insulin. I have also seen totally stone cold normal fasting insulin, A1C, and glucose, but an elevated LPIR. So I use them in conjunction or in tandem to help inform me about insulin sensitivity or insulin resistance. 345DF, do I use insert stents in my practice? When should stents be used, if ever? Yes, I put some in on Thursday. So I don't stent the heart arteries. Those are coronary stents. Those are put in by interventional cardiologists. I put stents in every other artery in the body outside of the skull base. So that would be the neck, the arms, the legs, and the pelvis and abdomen. Stents can do a couple of things. So you have to understand the architecture of them. There are stents that are open celled, so they are basically just a wire wrapping, but if you were to like run water through it, it would be permeable and you could get, blood that would go outside of the little cells of the stent. There are also covered stents that are a wire-based or a metal-based structural component, but also have fabric all around them. And those are impermeable to water and will actually contain blood within that covered stent area. So covered stents can be used to treat things like aneurysms because you are actually going to contain the blood only to the area with the stent in it, and the blood will push against the wall of the stent, but it will no longer push against the wall of the aneurysm, which will remain there, but is essentially isolated from the blood flow. So that's a cool way to use stents. But most commonly what people mean when they say, do you put stents in, is do you use a stent to stent open or pry open and keep open an artery that was narrowed or clogged? Those are typically the first kind of stent that I mentioned that don't have the covering, but they act as a scaffold. So what ends up happening is you have this like crunched down little narrowed vessel. What you do is you get a little wire and you stick the wire through the vessel to the other side where it's open. And then you put a little balloon over top of that wire and you stick the balloon through the nasty stenotic narrowed area and you inflate the balloon. So you stretch open that blood vessel and the plaque will stretch with it. It'll all kind of open up and then you pull the balloon out and the vessel may retract a little bit. It may spasm or it may recoil is the word. And you're like, well, it looked good when the balloon was up, but now the balloon's down. What if I wanted to just like make sure it kept open and I really wanted to support the blood vessel from the inside so it stays nice and round and widely open, keep that channel of blood flowing. Then you put a little stent and they start out sort of like wrapped and condensed all the way down. You stick that over the wire, you stick that like under the area that was narrowed or blocked, and then either the stent inflates itself, which is a self-expanding stent, or you use a balloon again on the inside to blow up the stent in the little metal cage, and then it sits on the inside wall of the artery and keeps everything open and pushes the plaque out to the outside. This is remarkably effective, but it's never normal. It is never the same as your own artery. These stents are an artificial material in your body that can be prone to clotting off suddenly. So if you know somebody who had one put in their heart, the stents in that situation are often coated with a drug, sirolimus, everolimus, anyway. They have a medication actually on that metal scaffolding that is intended to prevent the body from creating an aggressive immune response, because if the body mounts an aggressive immune response, you get new narrowing there. And so that's not great. So you try to prevent that, but it keeps the body from mounting this immune response and it makes it thrombogenic. It makes it likely to form clot. So people who get coronary stents in 2026 are almost all getting drug-eluting stents or DES, and they must be on dual antiplatelet therapy like aspirin and Plavix or aspirin and Brilinta, medicines that will keep the platelets from sticking for usually 12 months, sometimes 6, depends on the cardiologist and the circumstances, but largely that's about a year of dual antiplatelet therapy to keep those stents open. When should you have a stent? Eventually, I will get back to your question, I swear to it. When should you use a stent? So I'm not totally going to speak for the cardiologist because it's not really what I do, but I'm going to speak a little bit because a lot of my patients come to me with these issues. If you are not having symptoms from your heart artery narrowings like chest pain, shortness of breath, and it is not the big main trunk of the artery that leads to your whole heart, a stent is not that likely to improve your mortality or your long-term survival. You might get one anyway if you have a very aggressive cardiologist, but the data generally would support that stents will reduce angina, which is the chest pain that happens with exercise. And for stable angina, it's a reasonable thing to consider, although cardiac rehab, exercise, and goal-directed medical therapy may also really help with angina, and it may or may not do anything for your mortality under those conditions. If you have what they call 3-vessel disease, what does that mean? It means that basically all 3 major highways supplying blood to your heart are all severely compromised. Stenting or surgery under those conditions is probably warranted because you don't have any collateral pathway or any additional ability to compensate if one of them goes down or blocks off suddenly, right? You're in people who have only one, while the other 2 can probably feed the rest of the heart somewhat to give that person a chance to recover or get an intervention. But if you have 3 vessels, or it's the left main coronary artery, which is the very first portion of the left coronary artery right as it comes off the aorta, 3-vessel disease is considered left main equivalent. You don't need to know that. All to say, if there is a chance that one thing goes down and impacts circulation to the whole heart all at once, that is probably worth protecting. People will get stented or surgery for that reason in the heart. What about the legs, which is really where I put most of my stents? It depends a lot on the disease and what I'm treating and why I'm doing it. Some arteries take stents better than others. There are places I don't like to put stents, like right in the groin, the femoral artery, the common femoral artery. It's right where you bend all the time when you walk and stand and sit. Stents in that location can fracture and cause issues. It's probably not as bad as we originally thought, but in general, at least in the United States, we rarely put stents in the common femoral artery, but people will stent the superficial femoral artery in the thigh with impunity. The arteries below the knee historically did not do very well with stents. We have some newer scaffolding dissolvable technology that seems to be working better in those arteries, but despite being about the same size as the heart arteries, the ones below the knee did not do nearly as well with stents as the coronary arteries for a long time. Our newest generation of technology is arguably better, but that's pretty recent. So stenting is used for many things, scaffolding and supporting an artery to hold it open after it's been severely narrowed or blocked is probably the most common application, but there are a bunch of others that are kind of fun. We can get into that another time. Oh, Jimmy Mack, thank you so much. I appreciate that. 38 years old. Total cal of 252, CAC or total cholesterol? Probably total cholesterol of 252. LDL is 192. Took a coronary calcium score and had a 152. Dad had a bypass of 41. Doctor started me on 20 milligrams of Crestor with side effects, dropped down to 5. Major diet changes. What should be next step? Figure out what your family issue is. At an LDL of 192 at age 38, you might have familial hypercholesterolemia. You would need to get another test with another level of greater than 190 and then have a first degree relative like sibling, mom or dad who also had greater than 190. But if your dad had a bypass at 41, you absolutely have premature atherosclerotic disease in your family. You have the disease with a score of 152 at 38 years old. That's not a crazy high score, but for your age, it is much more severe disease than we would normally see. And figure out all of the other things besides your cholesterol that are a problem. I would, in a patient like this, typically also have you on more than one lipid lowering drug and with different mechanisms to try and balance the cholesterol synthesis versus cholesterol reabsorption pathways. So that's a fancy way of saying I almost always put people on rosuvastatin and ezetimibe. With that LDL, if you truly have FH, patients who have FH probably should be considered for PCSK9 inhibitor therapies above and beyond. It depends. The true correct textbook next answer is check your lipid panel in 3 months. But everything else I said would still stand in my practice. And I also think you have to figure out what else is going on. What major diet changes sounds good. I don't know what that means and what exactly problem you're solving with that. Maybe it's lipids only, maybe it's insulin resistance and inflammation, maybe it's overweight, obesity. I don't know. I would drill down on all of that, check a homocysteine, check a uric acid, check a vitamin D, and make sure you don't have sleep apnea, and see what else is going on. And that the first sign of any issues, get a CT angio, see what's going on. All right. Is there a blood test or test for insulin resistance, even if A1C is below 5.5, Amelia? Yes. So fasting insulin and a fasting glucose will allow you to calculate a HOMA-IR. This is the ratio between your fasting insulin and your fasting glucose. The way to think about this is how hard is your pancreas working to keep your to keep your glucose under control. Your pancreas secretes insulin to put glucose and energy in cells where it belongs to use that energy for the good and building things, anabolic hormone. So if your glucose is normal, but your insulin's high, then your pancreas is working harder than it should. Even if both are sort of in the normal range, but they're higher than expected, the HOMA-IR, that ratio will tell you how hard your pancreas is working to get you that normal glucose level. And that will precede hyperglycemia and probably precedes true hyperinsulinemia to some extent. Oral glucose tolerance test is another option. And the best way to do this is actually to try to fake a Kraft test, which means also measuring insulin along with the glucose measurements during that test. So again, you'll chug 75 grams of glucose and some kind of like gross cola thing. They'll check a baseline glucose and insulin level for you. they should check it at 30, 60, and 120 minutes. I mean, the more often you can get it checked, the better. I think most of them are actually just 60 and 120 minutes, but fine. So be it. And then again, you're looking for how high does the glucose go and how high does the insulin go to accommodate for that glucose load. Those are helpful things. Triglyceride to HDL ratio is another good test for insulin sensitivity and can be very illustrative, maybe elevated even before you'll see abnormal fasting glucose or abnormal hemoglobin A1C. Those are the big ones. Paul Elkins, yes, thank you for that. How do you calculate it? Most people will say HOMA-IR of 2 or 2.5. Higher than that is bad. Lower than that is good. I've heard somebody say 1. I use a cutoff of 2 personally. I think 2.5 is probably okay. Data on that are a little dicey about 2 versus 2.5. I don't think that's a strong thing, but if you're in that general range, you're probably doing okay. Jimmy, yeah, I appreciate that you're worried for your dad. Sedentary lifestyle, he was a smoker and way heavier. You are a former smoker. Yeah, cardiologist, I think, is a good next step. Again, make sure you have somebody who's like in your corner and on your side. I don't want you to find a doctor who's just gonna like, prescribe you pills and say everything's fine if it's not, or just dismiss your family history. That's tough. We talked a little bit about this earlier in terms of, how do you find a good clinician? I don't know. It's like finding the right pair of blue jeans. You kind of got to shop around until you get what you want. And for some of you in either very strict insurance plans or in health systems where you don't have the ability to do that, I'm really sorry. And I'm not sure how to fix that for you. We are doing our best to get the word out. You may have to get help outside of your healthcare system, outside of your insurance plans, and do some of this on your own. And I wish that were not true. And I wish I could figure out a way to make that not the case if you are in a health system that just isn't listening to you. I don't know I don't know how to fix that right now. We are trying. I'm hoping that the book will help get the message out there to people and allow clinicians to reconnect with what is good and worthwhile in what they do and help people come back to this place of like talking to patients and listening to patients and figuring out how to help instead of just prescribing drugs. But that's another soapbox. William, I like the cat, not the scan. Yes, thank you. That was Miss Morrigan, and I guess she got bored. I don't know where Freya is. Nevadan, my feelings on L-citrulline as a supplement for nitric oxide. Yes, this came up a little earlier along with L-arginine as a supplement for nitric oxide. Nitric oxide is just a tough one. We started this whole day with nitric oxide and ADMA. Exercise is the best thing for nitric oxide, in my personal opinion, which is a cop-out. It's a total cop-out because we don't measure it very well. ADMA is maybe not even that reliable. And do the supplements work? Beetroot stuff. Yes, there's some evidence for beetroot. There's some evidence for arginine and citrulline. Is any of it like deeply compelling? The PDE5 inhibitors, Cialis in particular, with a longer half-life, has been suggested, and many people in the like biohacking and longevity space take it and think that that's going to help. Maybe, I don't know. I don't think it's going to hurt you. And I don't, I'd tell you to follow the data if I really thought ADMA were a great test. I think it's an okay-ish test. So it's just really hard to figure out. And, we talked about EPAT and flow-mediated dilation. Should we be following these physiologic markers of nitric oxide in the blood? I don't know. This is a tough one. We are just not great in the nitric oxide space yet. I don't feel confident that any of these things are moving the needle an enormous amount. I think they're the last 2 to 3% in an optimization package or picture. And, it's probably not going to hurt you, but at some point there are all kinds of things that might help a little. And this is how my patients end up with a milk crate of supplements. And I don't know what's helping, what's not. And it becomes a little bit of a vicious cycle. Abdul, diabetes doctors don't do insulin level tests for 24 hours, just fasting. I hope there will be some instrument developed. Yes. Yeah, continuous insulin monitoring would be really interesting. Continuous ketone monitoring coming, that's also pretty interesting. It would be nice to be able to do that more often. I agree. Totally agree. Stents are artificial. Yes. Yes, they are. Um, what else we got? Oh, Lisa, thank you so much. Thank you. Mark Hunter, I'm a hard no for bread, and it sounds like all baked goods. Can I give more information why I went that way? Sure, Mark. This is fun. I can't stop eating baked goods if I eat them. So for me, it's basically a food addiction problem. And my love, my deep and abiding love for baked goods in particular is just really difficult for me to overcome. I can moderate a small amount of dark chocolate. But beyond that, I find carbs super triggering for me and I just can't stop eating them. So the solution for me was to cut them out and not eat them at all. That is not an approach that works for everybody. There are plenty of people who do well, who manage insulin resistance, who manage atherosclerosis with a higher carb, lower fat approach. Whole food plant-based typically is how they'll get there. Mediterranean can do this as well. All of those people who really emphasize the grains in there, and you can do it with quinoa. It doesn't have to be wheat-based, right? You could do like your pulses and beans and lentils and all those things. I don't have an objection to it as long as we have evidence that it's working for you. So if you don't have any problem moderating your consumption of baked goods, I think that's fine. I am concerned that like the modern wheat crop is perhaps more inflammatory than it was prior, but you know, the company where I buy my eggs, because of course I buy my eggs from some place that gives the hens massages twice a month or something, like this, all regeneratively farmed and it's very nice, but probably unnecessary. Nevertheless, they have all of these like ancient grains and they have a sourdough box, and I've thought about it and like, would I be able to have that and like not have any GI things and like not do that? The answer is probably yes. I could probably have some of that, and I would be limited in quantity because I'm ordering it from some place that sends it to me. I can't just go down to the grocery store and get more. Maybe. But do I need it? Really? Do I need it? Or am I eating it because it is a vice and it brings me a lot of pleasure, but not actually a lot of nutrition? Probably. So, that's kind of where I have landed for me personally. And I am leaning into the leaner proteins, chicken, fish. Somebody laughed at me recently for bringing up tofu, but honestly, like just as a fun experiment and to expand my culinary skills, I picked up some extra firm tofu and played with that for a while. I love a good steak every now and again. Sue me. And vegetables. Vegetables are great for me. I tolerate them in moderation. So, that's where I am. And it's different than what it was 5 years ago. And I reserve the right to change my mind and do something different in the next few years, depending on how things go for me. So that is a very long answer to a very short question. All right. Carbohydrates turn to sugar, artery damage. Yeah. Gerard, you're having hernia surgery coming in August. Thoughts on stopping your aspirin therapy before surgery? So your surgeon is likely to ask you to stop it, although the general surgeons are pretty reasonable and probably don't care that much about an aspirin. Unless you've had a stent in the last year, I wouldn't worry overly much about it. You'll be fine. You can stop it for a few days prior to surgery, and I wouldn't expect any major issues with that. All right. And GLP-1s. Yeah, the guidance for GLP-1s prior to surgery has gone back and forth a little bit. The ASA's recommendation was, I think, different recently. It used to be stopping a week before, now maybe not, but the fasting window might be longer. Just get guidance from if you're on a GLP-1 prior to surgery, get specific information. Your hospital or surgery center will have a policy, and just follow it. If it were me, and I were on a GLP-1 and going into surgery, I would have a longer fasting period than perhaps, or at least clear liquid period than perhaps what the center recommended, just to reduce the chances of anything being in my stomach if they were going to use a breathing tube. So that's what I would recommend on that front. Does aortic valve sclerosis always turn into stenosis? 1UP008. So not always, but it's the beginning of that process. And the mechanisms for slowing or stopping the sclerosis, I have no idea. Like taking care of your aortic valve is a totally separate thing than trying to manage your soft plaque. And I don't have great data other than if you have Lp(a), do what you can on that front. Try to avoid warfarin if you can. Try to take some K2 if you can. And maybe any of that will help. Unsure, unclear. Most of the trials have not shown any improvement using vitamin K to deal with aortic valve calcification. So even though I just said you might consider it, be aware that the evidence doesn't really support it. Yeah, cutting out jasmine rice is the hardest thing ever. Lisa, I have really struggled with how to be culturally sensitive for my patients who almost all, regardless of their heritage, have rice or starches as like a huge fundamental part of their native ethnic dietary pattern. I don't know how to like be helpful in those conditions, right? I have patients of Southeast Asian descent, of East Asian descent, patients of Hispanic origin, and like tortillas and rice and roti, and like all of these things are just ingrained in all of these native patterns of eating. And I feel very icky is the only word that's actually coming to mind. I feel very icky about like telling people they can't really eat what their whole life and their whole family and their whole culture has been built around, even if it's not serving their health. It's just, and cauliflower rice, I'm sorry, it's just not the same. It's just not. It's never going to taste the same. It's never going to be the same. And I don't know what to do about that. For people who are motivated, I find, having other clinicians who are in the space who are of those same either ethnicities or geographic origins, like many of them have figured out other hacks and other like ways to replace some of these fundamental foods, and like trying to find good resources for patients that way may be helpful. But I actually think it's really tough. It's really it's much more than like just what you eat, right? This is a bigger culturally sensitive issue for me. So I don't know. If you have suggestions, I am open to hearing about them and hearing your experience there. What is my favorite donut? You already know what my favorite ice cream is. How do you know what my favorite ice cream is? I don't think we've talked about this. My favorite donut is an apple fritter. My favorite ice cream varies widely. Probably right this minute, it's mint chip but Rebel. So if you're in the low carb realm, Rebel ice cream was my transition tool, and I have no sponsorship from Rebel ice cream, but very good. Findable in some grocery stores, but you can also order from them by the case online if that doesn't totally destroy you. Anyway, Rebel ice cream is a great low carb ice cream solution if you feel the need to bridge yourself into that thing. Favorite seafood. There is a misoyaki butterfish dish, which is a black cod that is done at a restaurant called Roy's. That is maybe my favorite seafood dish. I love that one. Really good Alaskan halibut. It was amazing. I used to hate oysters. I'm sorry, we're delving a little impersonal here. We're well past the 2-hour mark. I think you'll indulge me. I used to hate oysters, and I considered it a deep personal failing that I could not eat raw oysters. It was a texture thing. It was also a little briny, like the salty thing was not great, but like salty snot as a whole culinary experience, I just couldn't get there. But I hated that I couldn't get there, and I kept forcing myself to try eating oysters, which I think for a while like irritated my parents because they thought it was like a waste of a good oyster on somebody who didn't like it. But anyway, I now like oysters. I now really enjoy raw oysters. So keep at it, guys. You too can eventually overcome some of your food aversions if you are silly enough to keep trying to manage them over the years. And yeah, it'll be great. So I enjoy raw oysters now, and great sashimi, really great sashimi. If I had like one meal for the rest of my life, that's probably what I would pick, because there's just enough variety with different fish that you can, anyway. Amelia, this is a great question. Is the whole chilling a starch like rice or pasta and reheating to create resistant starch an option for an occasional indulgence? I think this is highly person dependent. I have tried this on multiple occasions with rice. I have tried it with sweet potatoes. I have tried it with pasta. I spike my blood sugar every single flippin' time, even with a moderate amount of it. So it does not work for me. My mom tried it as well, also had the same experience, but like there are a crap ton of influencers online who seem to say that resistant starch is great. It may provide some gut microbiome things and some hormonal things, even if it's spiking blood sugar, that are better than if it wasn't the resistant starch. I have no way to know or verify that. I have quit recommending it to patients as a strategy just because based on my experience, unless they are really comfortable with the CGM and can test for themselves. If it works for you, great, but I would proceed with caution. Chasing clean air. I'd been told vitamin K2 is necessary to take with calcium for proper absorption and to make sure calcium doesn't go into arteries. True or false? How to safely take calcium, amount and form, please. I don't love calcium supplementation. There's one trial that showed an increase in mortality. I much prefer people, if they eat dairy or eat calcium-rich foods, to try to just get calcium from food. I do think that K2, so vitamin D will help you absorb the calcium. I recommend vitamin D supplementation if your levels are probably below 40 nanograms. How much depends on how low you are, how much sunshine you get. Obviously, that would be the first strategy for getting your vitamin D level up. But beyond that, you'll probably have to supplement. And I just make that recommendation based on the serum tests. And then K2. So there are a couple of videos on the channel about K2. It might help reduce progression of coronary calcium score. It might keep some plaque out of the artery walls. It will not remove it if it already exists in your artery walls. That's a fallacy. But maybe it stops the deposition or slows the deposition. There's conflicting evidence on that. Nobody knows whether that's a good thing or not. We have no outcome data for this. It probably does improve bone health a little bit, the vitamin K2. There is no signal for harm for vitamin K2. So for that reason, I continue to recommend vitamin K2 with vitamin D3, despite the absence of evidence that it actually does anything for cardiovascular health. I don't think it's harmful. So I do recommend vitamin K2. What's the right dose for K2? Great question. Nobody knows. Nobody knows. Nobody knows. All right. All right. Termy Cobra, VA not recommending enough statin strength to get LDL below 555 milligrams per deciliter. CAC is 37, LDL of 110. Why wait for the inevitable? Seems insane. Yeah. Again, I wish that I could just apologize on behalf of the entire medical establishment. Even if you don't get it below 55, you should at least be targeting less than 70 with that CAC. Based on our guidelines, if that's where you believe. Anyway, oh, dang it, Paul, I had the fish capsule in my refrigerator ready to go for today, and I forgot it. I was actually going to do it. I swear to goodness, I was going to do it. But I left it downstairs, and now it's too late. Sorry. Next month. Next month. You'll have to come back next month. Will nitric oxide testing mouth strips? Can we check? So you can check for the conversion of nitrates to nitrites in your mouth, and that gives you some information about the oral microbiome and whether you have the good bacteria who do that conversion for you. I don't know how much it tells you about circulating nitric oxide levels in your body. Keto ice cream gagged me with a spoon. Sorry, Gerard. Don't look behind me. I know. Yeah. There's like Jaws music. David World Travel. Iron panel is normal. Ferritin remains low. Tried 3 forms of iron pills over the past 6 months. Do I have any advice? So some evidence for so first of all, the glycinate form of iron is probably the best tolerated from a GI standpoint. Take it with vitamin C. You probably already knew that. Every other day dosing may also be helpful for that. There is some evidence that doing it every day may suppress receptors. Every other day might be better. Basically, if you're not anemic, I don't know what to tell you about, like, whether you really need to drive the ferritin up by itself as an independent marker. I talked a little bit about that in my lab testing video. I'm planning to see if I can drive mine up without any particularly compelling evidence other than maybe some just curiosity. But vitamin C and every other day dosing and using the Ferroshell version of iron is probably where I would start. I don't know if those are already things you've done. All right. Does my cat eat kibble or do I cook special food for it like Princess Kitty? They get both. They get some freeze-dried raw and some like a little bit of regular kibble. They also get some gently cooked wet food twice a day because they are princesses. Of course. All right. Yeah, I know it's a bummer on the fish oil. I swear it's like it was ready to go and I just got rushed and didn't bring it. But next month, I'll keep saying it until I have to do it next month. Been on low carb keto almost 5 years, CGM to monitor glucose. Recent reading gave me an average 103, but A1C is 6.3. Which number is accurate? Good question. No idea which number is accurate. A1C of 6.3 for somebody on low carb keto seems higher than I would have expected. CGMs are not perfect. So a glucose monitor sits in the fluid in our tissues. It does not actually sit in the blood. And so especially the over-the-counter Stello Lingo glucose monitors, if you've ever calibrated them against a finger stick from plasma, they can be off by 10 to 15 milligrams per deciliter, which is actually quite a bit, even accounting for the lag, right? So what is in your plasma will take another 10 or 15 minutes, sometimes maybe even 20 to equilibrate with the interstitial fluid or that fluid that the monitor is sitting in the tissues. The absolute values of the CGM may not be that accurate. The trends should be. And if your average is 103, like I don't know, if you're low carb keto, I'm guessing you're pretty flat, but I would be doing finger stick testing and then just get a repeat A1C to check and see if that's real, because that seems strange. And sometimes the lab just makes an error. So I would double check that first. Christian, what are my thoughts on how well GLP-1s are doing and the many new versions and directions, treating diabetes, weight loss, blood pressure, metabolic health, maybe Alzheimer's? Christian, I think the GLP-1s are a fascinating group of molecules. I am pretty aggressive about using them in my practice. I'm also pretty aggressive about not using them at the normal dosages that have been used unless I'm truly treating a patient with severe overweight or obesity. But I target 1 to 2 pounds of weight loss per week in patients who have weight to lose. I have actually used them in patients who don't have a lot of excess adipose tissue. That is out there and like not necessarily, to be recommended for everybody. It takes the right patient to make sure that they're going to maintain muscle mass. They're not going to lose any lean mass, and you got to have a real clear indication for what you're doing there. And that's a far exception to what I usually do. Most of the patients that I use them in have some excess fat or a lot of excess fat. I think the signal for cardiac events is really interesting. So semaglutide has been tested. It's actually approved for cardiovascular risk reduction. Tirzepatide, which is Mounjaro or Zepbound, does not yet have that indication, although it has an indication for sleep apnea. And I think eventually the Zepbound will get an indication for cardiac protection. Retatrutide, which is Eli Lilly's 3rd generation GLP-1, GIP, and glucagon, is going to have an indication, I believe, for fatty liver disease. May or may not get an indication for cardiac. I haven't seen the outcomes data for those yet. The generations, I mean, they're variations on a theme, right? I prefer tirzepatide over semaglutide, mostly from a side effect profile standpoint. Everybody and their brother who's on Reddit believes that retatrutide is the best thing since sliced bread, and everybody needs to be on Reddit. And I've had, people's like 18-year-old sons coming to ask me about whether they need to be on Reddit, like in college when they have a BMI of 22. And I'm like, bro, no, absolutely not. So there's this whole peptide thing has really muddied the water for a lot of the GLP-1s and other molecules that also are called peptides, which is it's a term, it's a label, but it encompasses a wide variety of very, very different molecules that do wildly different things that should not really be lumped together other than like they are structurally made up of amino acids. That is the only thing they have in common. Anyway, overall, I think they're very, very promising. I think that lifestyle remains a foundational tool, and I try really, really hard not to use them in patients who cannot have some change in lifestyle. And those patients need some help anyway, right? If you can't do anything, if you're not, I'm using bad language here. If you are in crisis, if you are in metabolic and health crisis and we do nothing and all I do is tell you to, you can't have access to this until you're going to be on a, whole food plant-based diet and you're going to exercise 150 minutes a week and you're going to do this and you're going to do that and I need to see this and I have to see that. Like those people are going to stay in metabolic crisis and they're going to stay in health crisis. They are not going to get well. They're not going to get better. I have seen the GLP-1s be transformative for people who got just enough positive reinforcement, just enough feeling better to be able to start exercising again and to be able to have the confidence in themselves to make food at home and to make different choices and to buy a vegetable and to not buy an extra donut and whatever, right? They do more than just suppress appetite. We've had appetite suppressants around for a long time. There is something hormonal about them. I find that patients don't need the enormous doses. I find that encouraging and recommending strongly having conversations about resistance training and muscle mass is really important. I do a lot of nutritional counseling with patients about protein intake, about creatine supplementation and resistance training, and all of the things that I think make for a successful GLP-1 experience. I don't think giving anybody a GLP-1 and sending them on their way is any better than giving them a statin or an aspirin or a blood pressure medicine and sending them on their way without a conversation about how to use this tool appropriately and how to get the most out of it, because they're expensive and they are not accessible to everybody. And in small doses, I have seen them do really, really powerful things. So I'm pretty enthusiastic about them. I know people believe that there will be some terrible thing that happens and some class action lawsuit and it's all coming down the pike. And maybe that's true. I don't know. I don't have a crystal ball about that. I do think, like every other tool we have, there are ways to use them responsibly. There are ways to use them irresponsibly and inappropriately. And, they should not be the tool for somebody who wants to look better in their swimsuit for their upcoming cruise, who's then going to stop it and regain that weight and all of that. So, with great power comes great responsibility. Dardeem, what are my cat's names? This one back here is Morrigan. The other is Freya. Critical thought. I was making so much sense until my advocacy for GLP-1s. Weak for bridging only, in my opinion. Okay, we can agree to disagree on that. Since we are going over time, thank you, Lisa. You're so sweet. Christian just took my third dose of tirzepatide 2.5. At least I'm talking small doses. Yeah, most people I actually start on 1.25 of tirzepatide. So if I can, so that means usually they're getting cash pay and they're getting vials to do that. You can't do it with the pens. If you have pens only because you've had it approved through insurance, your only option for managing dose on that is to extend the dosing window. I have not been doing that as often, but it is potentially an option. It's probably a little less effective than smaller doses at the weekly frequency, but we do what we can. And I would say the vast majority of my patients on 1.25, 2.5, and I have a handful of people on 5 milligrams. All right, what else do we have in the anonymous question bucket before I give you guys all back the rest of your Saturday afternoons or evenings? What are the biggest disadvantages I see for opting for an enlicitide-only approach to lowering cholesterol? I think many people are statin averse for one reason or another. So enlicitide is the oral PCSK9 inhibitor. Lipfendra will be the brand name. We don't know yet. The PCSK9 inhibitors are powerful drugs. I do think there is, again, some synergy between cholesterol synthesis and reabsorption pathways. So I like Zetia in lots and lots of patients. I think it's helpful, but if you're on a PCSK9 inhibitor and you already have an ApoB that's down in the 40s, like, are you going to get a lot of benefit out of Zetia? Maybe not. In terms of, there seems to be a little less impact on inflammation from the PCSK9 inhibitors, at least the injectable ones. Like, we don't see as much reduction in hs-CRP as we did with the statins, or at least with Crestor from Jupiter. That may be a little bit of an issue. We may not get quite as much of the pleiotropic effects. I saw a paper recently looking at the role of bempedoic acid on clotting, and it took me down a very interesting rabbit hole. This is on the list of the other videos I need to make for you guys someday. But the statins, including Crestor in particular, actually have an antithrombotic effect. If you look at rates of deep vein thrombosis or the blood clots people get in the leg veins, they're lower in people who are on particularly Crestor, but statin therapy in general. We also see that in bempedoic acid. So bempedoic acid is another oral molecule that impacts cholesterol synthesis in the liver only. It really doesn't extend to the muscle. And the PCSK9 inhibitors may or may not have that as a class effect to the same degree. As we think about, what are the impacts of these drugs, we talk often about the pleiotropic effects of statins, and not just the LDL lowering, but also the lowering of the inflammation, potentially also some antithrombotic impacts, right? There's some thinking that for patients with familial hypercholesterolemia, it's actually a double hit of both the lipids and a prothrombotic state. So all of this is very interesting, and we just don't know yet what the outcome data will be for oral PCSK9 only yet, until we have thousands of patients who try it and we see what happens. But if the goal is just targeting ApoB numbers, fine, that should be adequate, and we'll probably get good results with that. Whether these pleiotropic effects are really meaningful clinically or not, I don't know yet. We talk about them a lot. They come up in trial data, they come up in outcomes data. Certainly for Jupiter, at least, the impact was relevant, like above and beyond the LDL impact, but I don't know, right? People hate Jupiter for a lot of reasons, and it's not been, we've not necessarily seen it replicated in another independent way. So I don't know yet, but it'll be interesting to see how that goes. I think it's going to be a big deal drug, and I think it's going to be, a lot of people are going to be on it for a long time. Other than health, what could I talk about for hours at a time? What could I talk about for hours at a time? We could talk about orchids. We could talk about arts and crafts. We could talk about exercise, which is health, so that probably doesn't count. And I think mostly it's health. I mean, you gotta spot me a little grace here. It's been a 17-year journey for me to get here, and so that's kind of where we are. For me personally, but I have to say I'm like a little boring outside of the health stuff for hours on end. I'm glad that there's enough people who care about the health side to watch me have a YouTube channel here, but if it weren't for that, I don't know what else we would talk about that would generate nearly this much support and interest. All right. GLP-1s like Ozempic and Wegovy are associated with small increased risk of vision loss. For the diabetic patients, that is true. There is that small risk for the NAION, non-anterior ischemic optic neuropathy. The risk of blindness from diabetes uncontrolled is also high. So, are there other medications? Yes, there are. You could use those instead. There are nutritional approaches. One should absolutely be using those in addition. We have not seen that same signal for vision loss in the use of these medications for overweight and obesity. So I don't know that is going to be the same signal. We'll see. There is still the black box warning for medullary thyroid cancer. The risk of pancreatitis is real. I've had a couple of patients who had it when prescribed by other providers. Mine hasn't happened yet, but it's only a matter of time. It's very possible and probably inevitable if I treat enough patients with it. It's a tool, and all tools, nutrition, lifestyle, everything comes with risks and benefits. Absolutely everything has a trade-off. So it's a big gun, right? I wouldn't do it if it weren't really helpful or necessary for some people, and what I would consider to be worth those risks, and what my patients consider worth those risks. But yeah, it's nothing's free. No free No free lunch. Jason, what are my thoughts on intermittent fasting? Discernible benefit for heart and cardiovascular health. I think fasting is an interesting lever for managing insulin and managing caloric intake or energy intake potentially, especially if it drives you into ketosis and generates enough ketones to help suppress appetite and all these things. The like 18-6 and the some of these truly just skip a meal a day windows have not been shown to be all that effective. Most people are finding more help with either prolonged fasting or one meal a day. Again, it depends on what are we solving for. Are we solving for reducing insulin and managing fat mass? Are we solving for overall longevity and trying to build muscle mass, at which point a lot of prolonged fasting may, reduce some of our lean mass, but we get more autophagy? It's a delicate balance. I don't know. I think for people, especially who are struggling with insulin resistance, who are struggling with excess adipose tissue, the excess fat, that fasting can be one tool. Some people it works really well for, and they really like it, and they feel good doing it. Other people do not like it. They do not feel well doing it. Whether they should buckle down and try harder or not, there are people who can probably answer that better. Jason Fung is the guy. There are a lot of other people who coach fasting and use that really regularly as part of their practice. I confess, I do not offer it as a thing I talk a lot about. I have done a couple of shorter fasts, 40 hours, 48 hours. I don't love doing it myself. Maybe I should try harder and have that as an experience to tell you all about and tell my patients about. If you find that super helpful, let me know. We can think about that as and add it to the list. What do I think of someone with very low hs-CRP taking colchicine? Well, I think if you have gout and an acute gout flare, then that's potentially why you might be doing it, at which point I would say you should also, at some point when the gout flare resolves, be on allopurinol to try to manage your uric acid and or figure out if there's anything nutritionally that is driving up your uric acid, like a high fructose load. But if you don't have an elevated hs-CRP, you don't have an elevated Lp(PLA2), you don't have an elevated GlycA or any other inflammatory marker, I'm not sure what colchicine is buying you or why it is helpful. William, I'll watch a 10-hour chat. Yeah, I don't know. People keep asking questions. We'll keep hanging out for a little while yet. I don't think we're going to go 10 hours, but I think we'll hit 3. Schizophrenia and heart disease, any connection? Absolutely. Absolutely. So most of the most devastating mental illnesses all have a component of inflammation and cardiovascular disease. Now, whether this is actually related to the disease itself or whether it's related to the modern treatments, which cause a lot of fat gain, is a little unclear to me, although I do think that there's actually a signal beyond the treatment effect, but it's highly stressful, right? There's this situation of your brain is at war with itself. And this is true of bipolar, it's true of schizophrenia, and all of the brain-based disorders all have a pretty big signal for increased cardiovascular mortality. Whether that got worse as we added all of the antipsychotics, the atypical ones in particular that are causing a lot of excess fat gain for patients. I am not as familiar, Georgia Eden, Chris Palmer would probably be the people who actually have a better handle on the relative contribution of the illness itself versus the damage caused by the treatments. But the short answer is yes, there's absolutely a connection. Patients who have those diagnoses have reduced lifespans, and many of them die of cardiovascular disease. Barbara, hi, 63-year-old woman, ApoE4 carrier. And yeah, your ApoB is 109, 133 LDL-C. Check out our videos on ApoE4. You will find some interesting information in there about what ApoE4 does, how it traffics lipids, what current guidelines and recommendations might be for how you would want to think about that, how big the lipid piece is in the whole picture. That's a really debatable question. Certainly, there's a lot of other targets and ways to manage risks related to ApoE4, both for the brain and for the cardiovascular system. But there is some interesting information on the lipid trafficking side of that in the videos that we have here. CIMT fine, Zetia, GI distress. So you worry about statins. Yeah, that's understandable. I would say, again, follow the data, try a low dose, see what happens to your blood sugars. And if it's a problem, then you can always stop. And then you can then have some evidence that you're intolerant to that and maybe have access to other drugs or other medications if that's relevant and important to you. Maybe it's not. That's cool. No problem. Oh my gosh, Lisa, I am 60 inches on. Oh boy. All right. Well, I'm glad it's easy for you to watch and read. That's the most important thing. Christian, my thoughts on creatine monohydrate. I took 10 grams today. I think creatine is a very safe supplement. I do resistance training, so for me, it supports that. I also have found that it supports my brain a little bit if I am not getting quite as much sleep as I should, which is a little bit of an occupational hazard for me from time to time. So maybe it's placebo. I don't know. There have been some studies that show that it should be beneficial for the brain, especially for sleep deprivation or some other sort of cognitively challenging scenarios. Personally, I just can't tell. I think it helps, so I have continued to do it, and I don't see the harm. Other than occasionally getting a little extra finger swelling if I increase my dose beyond what I usually take. But I think creatine is a good thing if you are doing a lot of resistance training. If you are not doing any resistance training, creatine is not going to help you. And then we should, see me after about why you're not doing resistance training. Okay. How am I doing? How are my parents doing? Do they watch my AMAs? My dad does not. I have shown him one of my YouTube videos. He's okay. He's okay. I have to go to one of his doctor's appointments on Monday and see if I can talk some sense into my dad. And mom probably watches some of them. 3 hours is a little much for her. So she probably doesn't listen to all of them. Okay. For ordinary people, how to get a coronary CT angiogram and heart flow at the lowest cost. I think cost is the highest deterrent. The best you're going to do is to see about getting your CT angio at a freestanding imaging center. Don't get it done at a hospital or a big hospital system. Get it done at like a Simon Med or one of the kind of community-based imaging centers. They will often have negotiated cash prices that will be the best you can do rather than paying out of pocket through a health system, which will have a facility fee and be more expensive. The heart flow overlay piece is a fixed price. You're not going to really negotiate that. I think it's about $800 last time I checked. And I don't know how to get that down for anybody. But the best you're going to do is save on the CCTA part and try to get that at a freestanding imaging center and ask for their negotiated cash prices. You may call around. They will be different at different imaging centers. So call a few places and, see what the difference is in distance and gas versus the cost of the scan. What else? What else? What else? What is my opinion of Dr. Davis's SIBO yogurt? I know nothing about Dr. Davis's SIBO yogurt. I think if you're making your own yogurt and having live active cultures, it's probably pretty good. SIBO is kind of its own thing, and I do not have enough of a functional medicine background or training to really, I know what it is, but I wouldn't manage it myself. Explain the difference between fasting insulin versus glucose. Okay, glucose is the energy molecule that we eat and that the liver makes. Insulin is the anabolic hormone secreted by the pancreas that moves the glucose from the bloodstream where it circulates into the tissues to have it do stuff, right? When we eat it, it gets absorbed. When the liver makes it, it gets just dumped into the bloodstream, but it has to get from the bloodstream into your muscles, into your brain cells, into your red blood cells, into your fat cells, into all of the organs and tissues that actually have to use the glucose and convert it into ATP for energy. So insulin is like the key that unlocks the door into those other cells and actually gets the glucose where it needs to go. So the glucose is energy, the insulin is the hormone that allows your body to know where to put the glucose and where it's supposed to go and what it's supposed to do. So how hard your pancreas is working to secrete how much insulin to manage the glucose is really the crux of the issue about insulin resistance. Thank you for all the great info. Use one of my links to schedule a CIMT for wife in October. If I have CKD stage 3 from chronic kidney stones, would it prevent me from getting a CCTA? Stage 3, it might not, but I would ask them or ask your doctor, whoever's managing that, your primary or your kidney doctor, whether they want you to do like a hydration protocol before your scan. And they may want you not to do it. I don't know. It's a question of, again, risks versus benefits. The contrast has a risk of something called contrast-induced nephropathy or kidney damage related to the contrast. The risk is low, but it's not zero. Most of the time it can be sort of managed and mitigated with, again, fluids and just making sure you're drinking a lot of water before and after to really flush it all out of your system. There is always a risk that it might worsen your kidney function, but I would work with your primary team or your clinical team on that and see what their thoughts are, depending on what your baseline creatinine is. Biomarker panel, would I recommend any further tests? So this is all lipid stuff. Again, check your metabolic markers, check your vitamins, check your other panels, and see what else is going on above and beyond just the lipids. Okay, sorry, whoever typed in the short novel. I'm not going to be able to read all that. I will see if there is a nugget in there, and maybe we'll find it in a comment response. How can a person reduce their arrhythmia risk? Somebody had a family member who just had a cardiac arrest and was a very active athlete. Unless you have an inherited family disorder about arrhythmias, I don't know that there's a great answer to that question. They are just a sudden catastrophe, and they happen all the time, and they happen to people in medicine. I mean, it's not one of these like major chronic diseases that we have. Athletes, especially like very accomplished athletes with endurance sports, may be at higher risk for developing arrhythmias later in life. Dr. Nabert, if you're still around, maybe you can speak to this a little bit. I don't know if there's really anything we can do to prevent that. That is a little bit outside my level of expertise. Does having a cold affect a homocysteine blood test? Probably not, although I'm not certain of that, but probably not. When I was discussing my labs, I mentioned improved oral hygiene, possibly contributing to the improvement in one of my scores. So is that more than just brushing twice a day and flossing? Do I have any special toothpaste or mouthwash? Paper coffee filters? So I do use a paper coffee filter. It's not because I care that much about its impact on my LDL cholesterol. It's just because it's how I use my AeroPress, and I find it more convenient to clean it with a paper filter, and I think it tastes better. And so I was not a regular flosser back in the day before I became sort of a prevention person. I am now a daily flosser, so that helped. I also had a crown that was a little bit wonky and eventually finally wore down enough that it had to get replaced. Maybe that had something to do with it. I did not have any abscess or anything related to it that I know of. I think mostly it was just like the routine daily flossing. I also, by the way, had a permanent retainer in my front teeth that made it hard to floss those. It wasn't hard, it was just annoying and I didn't do it very well. So I took that out so that I could floss better in my front teeth. That was really a game changer for me of all the silly, stupid things. And the mouthwash? No, I don't use mouthwash regularly. Sometimes if I get tired of flossing, I will use a water pick instead. I like that too. I will put a little bit of mouthwash in the big tub for a water pick. I like to dilute it. I think the full strength mouthwash, again, changes the oral microbiome. And if you're doing it every day, you may not convert your nitrates into nitrites so well and have your nitric oxide pathway, your beneficial bacteria, not help you in that way so much. So most of the Bale-Doneen like dentistry people would not recommend using an alcohol-based mouthwash every day for sure. But I don't use anything different. I got rid of fluoride in my toothpaste a while back, not because I think fluoride is evil, but because I was having a skin issue and I thought maybe that was related. I started using nanohydroxyapatite-based like toothpaste, and I just found that I am now in the habit of that instead, and so I just kind of like it. I don't know. I don't think there's I don't think that had any meaningful difference in my inflammation one way or the other. Okay. Any knowledge, opinion of consumerlabs.com for third-party testing of supplements? I think any third-party testing of supplements is good. I don't use Consumer Labs a lot. I don't have a great deal of information, but I would assume that they are a pretty reasonable source of that. And I would say carry on. If they are testing stuff and it seems okay, that sounds fine to me. There's not, right now we're in this like, well, get your supplements tested. Well, who's testing the testers? I don't know. Consumerlabs.com is one of the big ones. I think it's probably reasonably safe. Is there an age below which I think imaging is not worth it for someone who otherwise has good labs? Someone in their 20s with good labs get imaging in their 30s. Again, risk benefit depends on family history. If you have a strong family history of premature cardiac disease, I think getting imaged earlier rather than later is better. There are people in their 20s and 30s who are not going to change what they're doing with their health in their life, no matter what I say about their CIMT. So, get your imaging as soon as you're ready to be serious about your health and about your body and taking care of this amazing, miraculous vessel that we have that carries us through life. When you're ready to be serious about that, then come get tested. But I have at least one patient I'm thinking of in his early 30s who sees me and we've done stuff, but he's ready to be serious about it, and he's not partying every weekend and whatever. If you're gonna get imaged and then disregard all the information and go do what you want to do, that's fine. Go live your life, but like don't waste your time or money getting testing if you're not gonna use the information and take action. All right. Anything else in the chat? 10 to 20 grams of creatine daily. Can't subjectively tell if it's helping yet. Yeah, critical thought. I'm with you. I don't know. I think 10 is better than 5 for me, but I don't know. Would 15 be better? 20 be better? I don't know. The data are suggestive and interesting, but it's hard to know for us personally whether it's really making any difference. Barbara, my cardiologist performed a carotid artery test and said she did the IMT, but based on all of I discussed, is that it depends. If she didn't send your images out to CardioRisk or another of the really good labs, then it's probably not as helpful, truthfully. Rohit, what do I think of Scribe Therapeutics, a biotech company targeting cardiovascular disease? They are developing CRISPR-based genetic medicines. So I think if you have a single gene causing a significant predisposition for cardiovascular disease, like an LDL receptor mutation that causes familial hypercholesterolemia, perhaps those technologies are game changing. The PCSK9 knockout trial was very splashy in the media a month or two ago. And, we're going to just knock PCSK9 out of everybody and heart disease is going to go away forever. And maybe not. I think the risk for unintended consequences there is perhaps significant. I'm just not quite sure I'm ready to sign up for that yet. I would personally rather be taking a pill that I could stop or a shot that I could stop, even recognizing that there will be unintended consequences of GLP-1s, of the PCSK9 inhibitors, of all of these new agents that we have. Someday we will discover what the unintended consequences of playing with Mother Nature are, right? Some of them are going to be reversible and some of them are not. So we'll see. Again, if you have a genetic predisposition that is otherwise going to kill you in your 30s, sure, that seems like a really pretty good bargain for me. But beyond that, should everybody just get a CRISPR-based knockout for PCSK9? I'm not there quite yet. Maybe that's just a lack of imagination, but I'm not ready for that yet. Yes, Paul, all CIMTs are not created equal. That is correct. Does erythritol cause heart attack? Good question. I know there was some safety signal for erythritol. I don't know that I trust those data really strongly, and erythritol makes me feel like garbage, so I quit using it mostly. So I don't know. Again, unintended consequences. Dose makes the poison, I think. And I personally, again, a lot of people get GI issues from erythritol, so use it in small doses and it's probably okay. I wouldn't add it to a lot of things unnecessarily. LPD, welcome. Labs just came back. High cholesterol, ApoB, LDL particle count over 2200. IR score 57. Yeah. I'm sorry, man. So hard to know exactly what's going on without, again, the full panel and the full history. Even keto, I just, some of this is like there is still the ability to have excess energy on keto and develop insulin resistance that way. It doesn't work for everybody, and there's a lot of different ways to do keto or do low carb, and maybe tweaking how you're doing it is worthwhile. I don't know. I know the experience though of thinking that you're doing all the good things and everything right and getting a panel back or a test result back that is not what you were hoping for. Again, lab tests are interesting. The LPIR of those things is probably the most concerning. And I would get imaging and see what that really means in your body, right? Is that really deeply impacting your blood vessels or not? And that may be some helpful context for you going forward. Dr. Lilly, I have a crown, highly irregular for 28-year-olds. Bless your heart. Bless your heart. Yes, I have a crown. I had a root canal in residency when I was burning the candle at both ends and not being great about my dental hygiene and eating not a whole food approach of any kind. I think it was a popcorn kernel that ultimately did me in. Uh, Marathons. I will not be running a marathon anytime soon. Yes, Gerard, I know. Electronic device disease. We are getting long in the tooth here. All right. Anything else lastly in the anonymous before I wrap? Okay, guys, guess what? We hit 3 hours. You have been amazing. This has been so much fun. I love doing this. We will be doing it every month, last weekend of the month. Thank you, thank you, thank you for sharing your Saturday afternoons with me. I really appreciate you. This has been fun. Take really good care. Until next time.